Good morning, everyone. Some things are worth waiting for, and this is one of them. Thank you for joining us this morning, and welcome to our Region's 6th Harm Reduction Symposium. My name is Randy Hatfield. I'm the Executive Director of the Human Development Council, a local social planning council based in St. John, and I'm joined today and helped by Nancy Gessner. I want to thank her in advance for what will be a very exciting day. Your organizing committee has been busy putting together an agenda and attracting terrific speakers and panelists, and finding a name for the symposium that builds on the initial "Time's Up" phrase. This year, it's time lost. We're going to hear from speakers east and west today. We've got 2 panels set to go. We'll be monitoring the chat and question and answer, and you'll have a chance to raise your hands and ask questions throughout the day. The brochure is in the chat. There are very few housekeeping matters to attend to. We'll take breaks at 11:25 and 1:15. We hope you learn from today's proceedings. I want to thank our sponsors, Gilead and AbbVie. And in the absence of Todd Ross, I'd like to offer a territorial acknowledgement and acknowledge that the land that we're meeting on today is the traditional unceded territory of the Passamaquoddy, of the Mi'kmaq, Wolastoqey, and Pescatamakati people. 15 minutes has been set aside for opening comments, and I usually take this time to offer up some data that sets out some of the pressing social conditions that confront our communities, like the fact that in 2023, the child poverty rate in New Brunswick was 18.7%, or that 42% of children in Ward 3, one of 4 municipal wards in St. John, where I'm sitting, were living in families with income below the low-income measure, or that food security remains an issue for too many of our neighbors, or that New Brunswick continues to have some of the lowest rates of social assistance in the country. This month, social assistance caseloads rose to almost 26,000, representing more than 36,000 recipients, or that 2 nights ago, 328 unique individuals used an emergency bed in New Brunswick. But this year, we're opening up this slot for some commentary on a piece of proposed legislation called the Compassionate Intervention Act. It would directly affect harm reductions underway across the province. Beth Lyons, the Executive Director of the New Brunswick Women's Council, has agreed to speak about the act. The objectives of the Women's Council include, first, to be an independent body that provides advice to the Minister on matters of importance to women and their substantive equality, and to be strategic and provide advice on emerging and future issues. And in keeping with their mandate, the Council has offered recommendations to the government on sick leave for workers, provided feedback on the framework for accessibility legislation, released a statement on revisions to Policy 713 that they described as, quote, profoundly concerning, and authored a report outlining the Women's Council's concerns with the proposed Compassionate Intervention Act, concluding with a recommendation that the government, quote, halt the development of this legislation. Beth Lyons is the Executive Director of the New Brunswick Women's Council. She's a born and raised Brunswicker, originally from Riverview, but now living in Fredericton. Her work before the Women's Council includes direct services with youth in the Greater Moncton area. Outside of work, she's a volunteer with the YWCA Canada and the Therapy Dog program with St. John Ambulance. She also reports that she is proud to be a queer feminist trying to fight the good fight here in New Brunswick. Over to you, Beth.
Thank you so much, Randy. I'm really excited to be here today, even though I'm speaking on a piece of legislation that is really concerning. And I think it's really strategic to foreground this in the day that you folks are going to have. So as Randy said, my name is Beth Lyons. You can see on the screen that I use she and her pronouns. I'm coming to you from my living room in Fredericton, which means that I'm on the unceded and unsurrendered lands of the Wolastoqey, which means that I have responsibilities and obligations under the Peace and Friendship Treaties. And it's always important for me when I'm speaking as a public servant to acknowledge that, even if there was a prior land acknowledgement. And as Randy also said, my work is with the New Brunswick Women's Council. We're a public independent advisory body. And women is our core mandate, which to us obviously means both cisgender and trans women. And then we also very much stretch our mandate to include all folks who belong to gender minorities. So trans men, non-binary folks. We try to also advocate for them as well. And I'm really here today because of this Compassionate Intervention Act. Government had first brought it up in the fall and says that it is going to introduce it in the Legislative Assembly, which means try to make it a law this month. Randy wanted to make sure that this was brought up early in the day, as it's no doubt already impacting your work, or it is about to. So I'm going to use my time to talk to you about what we know about the Act, the Women's Council's response to it, which is very much informed by folks at Avenue B, Ensemble Moncton, a couple of different organizations, as well as some independent researchers. So it's the Women's Council's work on it that was submitted. It was informed by a lot of folks who are here today. And then I'll close out with some thoughts on how this ties into some broader issues. And if at any point I go too like policy wonky or machinery of government, please send Randy a message and tell him to interrupt me to pause and explain myself. Yeah, so government first said in the fall that they are looking to introduce a piece of legislation, so that would become an act, a law, that will allow judges and hearing officers to order individuals who are struggling with severe substance use disorder and who are not meeting their basic needs into treatment. So we're talking about involuntary or forced treatment. Right off the bat, I want to acknowledge that I'm saying severe instances of substance use disorder. That is not the language that government has used. In the throne speech, which is a speech that's given in the Legislative Assembly in the fall and sort of lays out government's agenda for the coming months. In the throne speech, when the Compassionate Intervention Act was spoken about, government used the language of severe substance abuse disorder, which is an inaccurate and stigmatizing term. So I don't use it, but I just wanted to make clear that when we say severe instances of substance use disorder, we're making some assumptions about what government meant to say when bringing it up. In the throne speech, this appeared under the Safer Communities section of the speech, which I think is telling, as is the fact that it is Chris Austin, the Minister of Public Safety, who has been leading discussion of this in the media. So far, the discussion has really been around treatment orders as, this is government, not me, life-saving interventions that would apply to extreme cases and bolster community safety. So it's that twofold of like supporting individual people, but also community safety. Unsurprisingly, Minister Austin faced pretty immediate pushback on this, a lot of it likely from folks in the space today. And his response to that pushback has been to position the act as the only alternative to ignoring or giving up on the issue or leaving people to die in the streets. That is obviously a straw man argument. No one is suggesting that the alternative is to do nothing. And there's one particular quote that Minister Austin gave in an interview that I think is really telling, where he said, all of these quote unquote experts that seem to think things like incarceration and, recovery facilities are not effective. What I would say is, what we're doing now is not effective, keeping people on the street. The sort of conflation of treatment with incarceration and calling experts, quote unquote experts, is quite telling to me. We've also, of course, heard Premier Higgs recently speak about this act and suggest that it would have saved lives from an encampment fire recently, which tells us, assumptions about how this law would be applied, and also just the conflation that's happening around addictions and homelessness being one and the same, rather than acknowledging an overlap, certainly, but not fully mixing up the two issues. Beyond that, we don't have a lot of details on the act. We know it's going to be introduced this month. Once it's introduced, it'll go through 3 readings, which makes it sound like a really robust process, but they're often, they can be quite perfunctory, especially when we have a majority government, which we do right now. And if it passes, I want people to know that it wouldn't necessarily immediately come into effect. With a law like this, what we're likely to see is the law itself be high level, and then that there will be regulations attached to it that really get more into the nitty gritty. And so what will happen is if the law passes, there would then be a regulatory process that does have a component for public feedback. So there would be a lag basically where they're developing regulations, getting feedback on regulations before the act actually comes into force. We also know now that even though Minister Austin has led much of the public discussion on this, it's actually Sherry Wilson as the minister responsible for addiction and mental health services and the minister responsible for women's equality who's going to actually introduce it in the legislature. We also know that the new treatment facility that they've budgeted to start developing in New Brunswick is not going to be where folks under treatment orders are sent. That space is supposed to be for folks who are there voluntarily only. So those are all of the details that we have. Despite details being scarce, we're really concerned. I don't think this is a crowd that I need to tell. This law isn't evidence-based. Before I leave, I'll actually make sure to leave you folks with the links to the brief that the Women's Council gave government on this, so you can see the full rundown of the research, all footnoted. It's all really laid out to make it very clear that there are very few times when involuntary treatment works. It's consistently outperformed by voluntary treatment. The few times where involuntary treatment might be effective, people have really robust supports during and after treatment. And not just check-ins and coordination of services, but social determinants of health level of changing their material circumstances. So it's likely not going to work for many people. It's going to put many people at risk of overdose if they are released back into the exact same situation and conditions they were pulled from. And the money that this is going to cost can be so much better spent building up other services. And you folks all know that. And you also know that discussion of this already has been very stigmatizing, and that if treatment orders do become available, that's going to be further stigmatizing. And it's also going to drive people away from services, and not just services around substance use, but any sort of services they need. And it's not just going to be people who might be subject to a treatment order, but basically anyone who is visibly poor and is used to being surveilled is going to be more reluctant and fearful to go and get services because they know treatment orders are an option. So poor folks, yes, but especially poor folks who are also racialized, who are queer and trans, who are mentally ill, neurodivergent, or otherwise disabled are all going to be particularly fearful and driven away from services. So all of this is in our brief to government, along with recommendations like halt development of this law, as Randy said. Other recommendations are to invest in social infrastructure and to please make evidence-based policy that is co-created with experts. And when we say co-created, we're not talking about consultation or engagement. We're talking about a sharing of power. And then we also said, please stop dismissing experts and dismissing their expertise when the research that they are bringing to your attention doesn't align with your preferred policy directions. And then to sort of close up on this, I want to talk a little bit about why the Women's Council dug into this issue. We really view this in line with the changes to Policy 713, which impact how trans youth are supported in schools. On both Policy 713 and the Compassionate Intervention Act, government is focused on a marginalized and very misunderstood population and is advancing policy that isn't evidence-based, may well violate charter rights, and that is likely to actually hurt the population that it says it is meant to support. And then around both these issues, we also have public discourse that is just incredibly stigmatizing and harmful. So that is one of the reasons, we view this as a real continuation of the kind of policy that we started seeing, not started, but that we really saw was quite egregious with Policy 713. And then the other reason that we really dug into it was just the logic of the policy. If we acknowledge that forced treatment doesn't work as a healthcare intervention, you have to ask what the logic of the policy is, or the legislation. And to do that, you look at what it's likely to accomplish. And so if we're honest about what forced treatment is likely to accomplish, it's very clear that the purpose of the act is to remove or it's very clear based on what we know about the act so far, that the actual logic of it is to remove certain people from community and to do it without going through the criminal justice system or the Mental Health Act. And that should worry us all. It should worry us that government is proposing harmful and stigmatizing legislation and isn't being upfront about the logical endpoint of that legislation, which in this case is effectively the creation of a new kind of detention under the guise of healthcare and expanding institutionalization as a practice in the province, where we all want to move away from institutionalization. And for the Women's Council, this ties into the broader issues of people's trust in government is eroding, and moves like this do not help. And we are particularly concerned about people's trust in government being eroded when we're seeing the far right on the rise, and we are seeing the far right increasingly influencing mainstream public discourse and at times governments as well. So that is another reason why the Women's Council really dug into this. And I will also just say, like, as a former nonprofit person, I know what it's like to see government policy be proposed that is not good, not evidence-based, harmful, but also to be so busy doing direct service that who among you like has the time to write and research a 10-page brief, get it to government, and then also do the follow-up to make sure it's actually read. So in some ways, this was also like a bit of a love letter to the nonprofit sector to just say that we know the conditions that you're working under. And this was a piece that we were able to do with support from people who were doing direct service. And so we were happy to do it. That is it for me. I'm going to share those links, like I said. You're welcome to share them as well. It's publicly available. And my email is listed on the GMB website, so you're also free to reach out to me as well if you want to follow up anything or if I can be of help. And just, I know it's always cheesy to be thanked for the work that you're doing. I feel weird when people do that to me, but thank you for the work that you're doing. Back over to you, Randy.
On the behalf of those that are participating today and observing, I want to thank Beth for her presentation. I think it's a timely session to take into account that in the near future we'll be dealing with an issue that is going to require a level of solidarity that we sometimes don't see in the province. And I hope that you'll stay tuned to this matter and follow it as it moves through the House. Our first speaker today is Dr. Thomas Brothers, and he's going to speak on how can we make hospitals safe for people who use drugs, calling on lessons learned from Halifax and beyond. Dr. Brothers joins us from Halifax, where he is in his final year of subspecialty residency in general internal medicine at Dalhousie University. His clinical and research work focuses on improving health services for people who use drugs and alcohol, including the integration of substance use care into hospital settings. With colleagues and friends, Dr. Brothers helped to organize and implement Halifax's first supervised consumption site and first hospital-based addiction medicine consultation service. He has co-authored Canadian national guidelines for take-home naloxone programs and supervised consumption sites, and he is the Atlantic Regional Clinical Lead for the 2024 update of the Canadian Opioid Use Disorder Management Guidelines. It's a perfect combination of education, interests, and impact to get it started. Dr. Brothers, welcome, and over to you.
Thanks very much, Randy. Can everyone hear me okay, and can you see my slides?
I can.
Okay, great.
Yes.
Thanks very much. Okay, thanks very much for inviting me to participate in the Harm Reduction Symposium. Again, it's an incredible initiative that you've all organized here, and I thank you so much for continuing to push these conversations forward and organizing, contributing to organizing this group across the whole Atlantic region. It seems, not just New Brunswick. I recall really fondly the in-person symposium, I guess, back in 2019, and all the energy there. But it's amazing to see the reach that can happen when this happens virtually. And before I begin, I just want to acknowledge that when we're talking about health services, that these aren't happening in a vacuum. I really appreciate everything Beth shared earlier, and I want to agree with loudly and underscore all the concerns she raised as it touches on evidence and the harmful potential role of individual treatment interventions, especially ineffective ones, for what are actually social, political, economic problems. So thank you to all that are advocating against these harmful policies, and just want to acknowledge that when we're talking about health services and hospitals, that it's happening within this hostile environment against people who use drugs. It's not happening in a vacuum. I also want to acknowledge that I am speaking to you today from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq. We're all treaty people. I don't identify as a person with lived experience of substance use, so I want to recognize the generosity of people with living experience of criminalized drug use who've shared their knowledge and experience with me and helped me unlearn a lot of the harmful, wrong things I learned about substance use, and helped me learn a whole new way of thinking about this. I want to recognize the generosity of colleagues across the country who continue to teach me and who have shared resources, including some of the slides I'll share with you today. And I hold research funding from university and government sources, but I have no financial relationships with industry. There's some key messages that I want to communicate with you today, and I'll summarize them again at the end. A couple of years ago, I got to speak with you on a related topic and shared some information about our needs assessment in the hospital. Today, I want to share with you the whole story of our journey of trying to improve care. In some ways, folks in New Brunswick are well ahead of us in Nova Scotia, and in other ways, perhaps we're working side by side and learning from each other, which is amazing. So happy to chat at the end and share strategies and learn from all of your experiences as well. The first message is that hospitals should partner with and learn from community-based harm reduction organizations who are already doing this work. Second is that people who use drugs are experts in their own lives and should have leadership roles in improving care and policies. And the final one is that advocacy outside the system or the institutional bureaucracy can be quicker, and that's a lot of what we've done in Nova Scotia, but additional strategies are needed for sustainable change, and that's the concern with a lot of the things that we've just been doing on our own outside of institutional policy and structures. The outline for our session today for the next 45 minutes or so is first sharing some background information on how hospitals can be harmful for people who use drugs. Then next, I want to walk you through our journey in Halifax through various stages of service development and policy development and specific interventions we've been able to offer. And then finally, share some reflections and next steps, and hopefully we'll have time for Q&A and discussion afterwards. And I just want to frame this around the human beings that we're trying to improve care for in the hospital. This may be a situation that's recognizable to either people with lived experience or clinicians who are caring for people in the hospital. A young man with a very dangerous and life-threatening infection of a serious bacteria in the bloodstream in the heart developed cellulitis at an injection site 3 weeks ago, but had such negative experiences with healthcare settings, he didn't feel safe coming to the emergency department to get antibiotics, and he's had trouble getting primary care. He injects hydromorphone and has for several years. And if you do the math on the opioid equivalent conversions, it works out to around a gram to 1.5 grams a day of oral morphine equivalents. So for people who are prescribers or familiar with opioids, this is like a different category than we think about as using opioids for treatment of chronic pain. He's had multiple overdoses recently. He's been using more fentanyl recently because that's been more available. It's been harder to find hydromorphone, and hydromorphone's been more expensive. Fentanyl's cheaper for him. He's unstably housed, been staying on friends' couches. He's in pain, and he's already left the hospital multiple times in the emergency department despite this life-threatening infection because his pain and withdrawal haven't been adequately managed. And when the clinicians ask him what he wants to do about his infection or his substance use, he's says that he's come to the hospital because he doesn't want to die and he wants medical treatment for his serious medical issue. And that's what he's asking us to focus on at the moment. So just a way of background to start. One of the reasons that we're here today is because of the crisis of ongoing death from the toxic drug supply across the country. I'm sure everyone's familiar with these horrific numbers. A couple of things I just want to clarify about what our policy decisions have done for people who use drugs and where this danger is coming from. The risk of drug toxicity death is really driven by the toxic and unpredictable drug supply. So this figure is of all drug-related deaths with an opioid present at the time of death for the last 20 years in Ontario. And you can see that in 2015, 2016, 2017, this blue line here, the deaths involving fentanyl and fentanyl analogs started skyrocketing up. The deaths involving other types of opioids, including prescription opioids, has stayed the same. And recent data from Statistics Canada shows that the actual prevalence of opioid use disorder in Canada hasn't increased since 2012, the catastrophic number of deaths come from the toxic drug supply. For reasons not completely clear to us, the rates of serious infections from injection drug use are also increasing, probably for transitions in the drug supply, increasing rates of homelessness and material deprivation, rates of cellulitis, endocarditis, other types of bacterial infections that lead people into hospital are increasing. And several years ago with Duncan Webster and his team, we reviewed cases of injection drug use associated endocarditis in New Brunswick and found that those are also increasing over the same time period. In the community in the Maritimes, we have a network of incredible organizations that are doing life-saving work, supporting people, developing long-term supportive relationships, helping people navigate the world, and also providing all these evidence-based harm reduction interventions to reduce people's risk of infections and reduce the risk of dying. But when it comes to hospital settings, we not only have not incorporated that sort of care, we've excluded those organizations and that way of thinking from what we consider mainstream care in the hospital. So it's been horrific, magical thinking that somehow people who use drugs are different when they come into the hospital, harmful and unrealistic expectation that people will suddenly stop using drugs, even if they're just coming for medical treatment and they weren't seeking addiction treatment when they came into the emergency department. So one way to think about this is that hospital policies that require abstinence in order to receive life-saving medical care, either written or unwritten, in Nova Scotia, ours are currently a lack of harm reduction supports and stigma pervasive throughout our society, but also in healthcare, all contribute to people delaying their presentation for medical care when it's needed, like it did in the case at the beginning. Inadequate pain and withdrawal management in the hospital, so people have to treat themselves, including stocking up on substances before they come into hospital or leaving hospital to go acquire their own medications. And premature discharges against medical advice or before people's medical conditions are stabilized. This all is our system level issues, not the fault of individual people who use drugs, but system level issues that contribute to poorer treatment outcomes and increased morbidity and mortality for people who use drugs. I'll share with you some quotes, and I shared this study a few years ago. It may be familiar with people, but qualitative research on people who use drugs when they're admitted to hospital, highlighting some of these issues. The first, I had to get out of there while I could move because I was losing so much weight. I begged and begged to get some help, i.e. prescription opioids for withdrawal and pain. They weren't going to do anything about it, so I said, fine, I'm leaving. I was concerned about the health consequences of leaving hospital. You know, I've got this other thing, opioid dependency, and it's like you're stuck between a rock and a hard spot. I mean, how can I fight off the infection if I can't stop puking or shitting? The security guards yell and scream at you. When there's no one around, they say, you effing junkie. A few times I've been shaken down, searched by security guards, even though I had nothing to get high, no drugs in her possession. They search you, destroy your property, cause a scene, make sure everybody there knows you're a drug addict. They use their authority to pull power trips, more or less. It's not right. And the last two here. The nurses don't give us syringes. I think they should. If not, we're reusing our rigs, or we're having to risk getting kicked out for stealing them, or people will be sharing them. I know one girl was using her same rig for days to the point that she was tearing and she was suffering every time she'd do her fix. She just didn't have it in her to go and try and steal Korean legs because she was so sick. Whereas for me, my friend that I was with had no problem. She would just sneak in and grab some for the both of us. If you're sharing a room with somebody, there's always that threat that someone's going to come in and not realize you're in there, the bathroom, and open the door. I think they pretty much have a zero tolerance policy in the hospital. I was worried about getting kicked out and not getting the proper health care that I needed to get better. I'd turn the tap on, so if they came in the room to check to see if I was okay, they'd hear the water running and they'd figure, oh, she's just in the bathroom. So in a city in Canada where people have access to sterile injecting equipment in the community, it's restricted in hospital. And so they're having to reuse contaminated equipment or use used contaminated equipment from others. And in a city where there's supervised consumption sites in the community, they are restricted in the hospital. So people are having to lock themselves in their bathroom and use alone. We're increasing the risk of overdose death. Again, system policy level issues harming people who use drugs that could be different. During my PhD fellowship, I got to contribute to this study of the risk of hospitalization on opioid-related overdose deaths. We looked at all of overdose deaths in England between 2010 and 2019 and looked at when people were admitted to hospital and when they were discharged and their relevant risk of an opioid overdose. We found that during a hospital admission, people's risk of an overdose death was the same during the first 2 weeks of their hospital stay as it was during the community. So people are continuing to use drugs in hospital, as we know. After people were discharged, it's 4 times higher the risk in the first few days after hospital discharge compared to other times when they're living out in the community. And if the discharge was premature, against medical advice, as we label it in the healthcare system, the risk of an overdose death was 8 times higher. So the actual process of being discharged from hospital, and especially if the care is poor, the care quality is poor, and people have to leave on their own, are increasing the risk of overdose deaths. So back in 2015, when I first started my internal medicine clerkship, this was the sort of care that we would provide to patients who came to the hospital and that we would have provided to the patient case in our example. And I participated in this care as a medical student, and I thought this was normal, and I thought this was okay. We refused to provide opioid medications because the patient was addicted to opioids, and we didn't want to make their addiction worse. We used stigmatizing and judgmental language about people who are sick and people who are human beings with a right to healthcare. We restricted them from leaving the unit because they might use drugs. So we called security when they tried to go outside for smoke. The patient left the hospital before their medical treatment, even though they had this life-threatening infection. We, as clinicians, blamed them for non-compliance with the care plan. And then they got even sicker, got a fever, got incredibly unwell, and passed out. And somebody called an ambulance. They were brought back to the emergency department even sicker without their antibiotics. And it turns out afterwards, I didn't know this at the time, but our harm reduction outreach organization Mainline in Halifax continued to support this person throughout their hospital stay. Just they didn't feel safe connecting with the healthcare team either. So we were making things worse, and they were trying to support people. So next, I want to share with you our journey in Halifax since 2017, 2018. So back in 2015, we had several different regional health authorities in Nova Scotia, and they all amalgamated. And at that time, all the regional health authority policies became inactive. So if you look back in the policy archive, there are horrific policies from the regional health authorities about searching people's bags, taking away their possessions, calling the police on them, putting stickers on their chart to label them as someone who uses illegal drugs, saying that the hospital is going to get charged with possession of drugs if we allow people who use drugs to be in here with their own possessions, which isn't true and isn't a thing. So in 2015, all those policies became inactive, and we still don't have any active official substance use policy. So we're in a vacuum. As I mentioned, Mainline, for many, many years, since their existence, is my understanding, continues to support people when they're admitted to hospital. And Mobile Outreach Street Health, our street nursing primary care service in Halifax, continues to support their clients and patients in hospital as well, even while we weren't helping. And so I started phoning these organizations when we'd have these patients and saying, they're asking for help, and we really don't know what to do. And when I asked my supervisors and the attending physicians and that sort of thing, nobody has any ideas. And Mainline and MOSH folks would say, well, there's 10 things that you could do to help this person today to improve the quality of their care, and there's 20 things that we could do before they're discharged. So let's start working on it together. I learned from many people about the clinical skills of prescribing medications and opiate agonist treatment and withdrawal management. And I learned from many people in the community about how to provide care differently, about what harm reduction was, about what it means to provide relational and trauma-informed care. 3 in particular that people may recognize here have been incredible mentors to me. Natasha Pace, a person with lived experience, a founding member of the Halifax area network of drug-using people, who unfortunately passed away a few years ago after several medical complications. Patty Melanson, the founder of MOSH, also unfortunately passed away from cancer a few years ago. And then John Fraser, physician, family medicine, chronic pain, addiction medicine, taught me a lot of things and retired a couple of years ago, but 3 in particular who have had an influence on what we're doing in the hospital. We undertook a needs assessment. So did a chart review of everybody who admitted to hospital with endocarditis from injection drug use. These are folks whose infections are life-threatening. The quality of care we provide should be excellent. They should be prioritized for outstanding care. Some of it can be quite complex, like need to stay in hospital for a while for intravenous antibiotics, need ultrasounds of the heart and CT scans, and sometimes open heart surgery for valve replacements. But of course, that should be the priority. And we compared the care in hospital in Halifax to the care in hospital in St. John with colleagues at St. John Regional Hospital, who since 2007 had developed a culture and some policy directives around harm reduction in hospital that were, as far as I understand it, leading in Canada and continue to push things forward. So this involved care pathways for opioid withdrawal, setting a minimum standard of care, inpatient policy for needle and syringe distribution or needle exchange, and the infectious diseases physicians, led by Duncan Webster, were trained in opioid agonist treatment. So when they were consulted on these patients with life-threatening infections, could offer them withdrawal management, could offer methadone, buprenorphine, and transition patients to outpatient care. So as it might not surprise you, the care was incredibly different in hospitals. This is just one snapshot of it, looking at people with opioid use disorder that was untreated, came into hospital with life-threatening infections. In St. John, 100% of patients were offered OAT, and most of those who were offered it went on to continue it after their hospital discharge. And in Halifax, less than half, around a third, were offered opioid agonist treatment in hospital. But most of those who started it went on to continue it after discharge. So the second stage here is the huge gap. People who are interested in treatment in hospital want to start on it and continue on it. And we were not, again, a system level institutional issue. We were not equipped to provide the basic minimum standard of care for opioid use disorder. We found in the quarter of the hospitalizations in St. John, people were offered sterile injecting equipment, despite that policy saying that they should be able to across the hospital. Whoops. And 0% in Halifax. And that in Halifax and St. John, patients had their own equipment, their own sterile injecting equipment confiscated at both hospitals. And then we found across hospitals instances of documented in the medical chart of untreated pain and opioid withdrawal, ongoing substance use in hospital, and premature hospital discharges against medical advice. So still opportunities to improve care across both hospitals. So in Halifax, we found this to be obviously unacceptable. And a number of residents that were wondering how we could improve care for these patients, including internal medicine, psychiatry, emergency medicine, anesthesia residents. We started organizing to get trained on how to offer these medications and understand what the evidence-based treatment for substance use disorders was and offer it to patients right in hospital. We were doing this in addition to our residency. So it's mostly like evenings and weekends or on post-call days. And we had physicians in the community that did family medicine and addiction medicine supervise us from afar. And then John Fraser would come into hospital to round on all these patients once a week, or we would at least be able to meet online. So we did an evaluation about 18 months in, and we found that of all the patients with untreated opioid use disorder coming into hospital with serious medical complications, 82% started treatment in the hospital. And of those patients that we started in hospital, 89% continued after discharge. So of course, people don't need to be interested in addiction treatment or even start it to be deserving of medical care or to have a right to medical care. But we also found that hospitalization is a reachable moment. And for many people, it's an opportunity to change things and to start on treatment. And when we did offer it, the uptake was very high. We also started to develop some institutional responses. So this is an example of the pre-printed order set for initiation of buprenorphine in the hospital. It's a very straightforward algorithmic thing to do. It can be done in pre-printed order sets. As far as I know, this draft is still not implemented at institutional level. So we just printed off the draft PDF and had it available in the emergency department and the hospital ward for physicians to copy out. We started aggressively offering treatment for opioid withdrawal in hospital, asking patients what their home dose is and trying to match it in a safe way as possible. We initially this wasn't done culturally and institutionally at our hospital, and patients were left in severe opioid withdrawal. And so pushing the doses of opioid tablets and then some injectable short-acting opioids made an enormous difference, allowed patients to stay and get medical treatment. And then for some of them, when they were feeling a bit better, to be able to have conversations about what their goals were and if they wanted to start treatment. We initially got some concern from colleagues in the hospital that high doses of opioids would be dangerous and that we would overdose people because these are much higher doses than people were used to treating for pain after surgery, for example. So we would do things like provide the initial dose of the opioids at the bedside with our nursing colleagues and revisit an hour later and see how people were. And if they were still in withdrawal and walking and talking and breathing normally, of course, we weren't overdosing them and we could increase the dose or double it or continue on or adjust the dose and all those sorts of things. We also got lots of concerns and feedback that healthcare providers mean well and they want to do well by their patients. And there was this kind of misguided sense of moral distress around making an addiction worse by giving opioids for pain or withdrawal. And so we reminded people that, these patients came to our acute care hospital because they wanted medical treatment or they needed medical care, not because they were seeking abstinence-based addiction treatment. Many of our patients were not in recovery or did not identify as being in recovery and were still using drugs that day, let alone, recently. Some patients, of course, had preferences around which medications to use or to avoid, and some patients in recovery or early recovery wanted to avoid Dilaudid, for example, and that's great. Like, of course, shared decision-making is still an incredibly important principle when people have addiction, perhaps even more so. But when people are actively using opioids, we're not making addiction worse by providing them with a pharmaceutical grade, safer opioid in hospital compared to what they would have to go out and get on the street. And indeed, undertreated withdrawal or pain is more likely to lead to ongoing opioid use in hospital. If we can match what people need so that they feel well, then they'll use less from non-medical sources. We were also able to introduce take-home naloxone kits into the hospital. So here was an institutional asset, probably. Nova Scotia has a province-wide publicly funded program to provide free take-home naloxone kits at harm reduction organizations and community pharmacies. And the uptake has been really good in Nova Scotia. Almost every community pharmacy has naloxone kits available. There's obviously still a barrier there, but it's done anonymously and it's free. So the way this was organized for health and social services was that they could be registered as a distribution site with the take-home naloxone program. So these policies already existed at the health authority level, and we just had the internal medicine ward and the emergency department registered as distribution sites for the provincial program rather than working within the hospital to get this approved. And the policy says that, you need to be trained or equipped to educate patients and distribute them. That's okay and is appropriate. So physicians and pharmacists were doing this initially. Nurses, if they wanted to take the extra training, could do it as well. But the kits were free. We could stock them with boxes supported by the Nova Scotia Take-Home Naloxone program that would do train the trainer and that sort of thing. We ran into, we were giving them to people even when they were admitted so that they could, if they were going to be using with other people or leaving the hospital and coming back, they could make sure they had naloxone. And even when people weren't using them, initially they were, I think, quite a powerful tool to show people that we cared. I had several patients be shocked and surprised that we were offering them take-home naloxone kits so that we knew what they were and that we wanted them to have them while they were still in hospital with lots of positive feedback from patients. We ran into some barriers. This isn't in the news anymore, but back in 2018, 2019, there were lots of news stories about this untrue urban legend of naloxone parties, where teenagers would be purposefully overdosing each other at their parties so that they could give each other naloxone as a dangerous rush or something like this. And it seems unbelievable. It's not true, but a senior administrator in the emergency department had heard about this in the news, and so delayed the implementation of take-home naloxone in the emergency department for 3 months because they had heard about this urban legend. So these do real harm, these urban legends. As healthcare providers, we have an obligation to counter them. And it's just unbelievable to imagine another healthcare initiative delayed because an administrator read about something in the news and was hesitant to implement it. Like that would never happen for diabetes care or cardiology or whatever. It's outrageous. Mainline distributes sterile injecting equipment through a very cool initiative around the southern half of the province called the Brown Bag Program. So all of the equipment that people need for a few days of use is packaged into brown paper lunch bags and stocked in community pharmacies around the province. For mainline, that's everything Halifax and south of Halifax down the South Shore in Nova Scotia. So we again leveraged this existing resource, asset, and strength, and just started stocking brown bags in the emergency department initially. Again, there's no specific policy in Nova Scotia Health that supports this or bars it. So we just started doing it. Physicians initially would distribute it. The pharmacists got on board as well. We've then started bringing those brown bags from the emergency departments up to inpatients, started stocking it on some of the inpatient wards, and our new addiction consult service, which I'll talk about in a sec, started offering them as well. We've run into some barriers there because there's no institutional policy to support it. So, for example, the nursing college has said that they can't ensure nurses are safe doing this, or it's within their scope without a policy. So we've only been able to do it on some units and primarily with physicians distributing the equipment, which is limiting access. So this is another place where some hospitals in St. John, maybe in New Brunswick, especially in St. John, maybe well ahead of us, but happy to chat about that. In terms of how to frame this at an institutional level, we've learned from colleagues, this policy comes from Providence Healthcare in Vancouver, BC, and it explains how distributing sterile injecting equipment and making sure people have access to sharps containers actually reduces the risk of needle stick injuries in hospital. That if patients have access to equipment and they know where the next one's going to come from, that they don't have to hide needles and reuse them. So they won't be under the mattress. They won't be in the peanut butter drawer on the nursing ward in the room or whatever. They could just dispose of them safely and get more. We used that data from our program evaluation from our resident run informal addiction consult service in a business case since 2019, delayed a bit, probably in part because of COVID. And then finally, this past September, launched a real addiction medicine consult service at our main acute care hospital site that serves inpatients and the emergency department at that site, staffed by a physician Monday to Friday, 8 a.m. to 5 p.m. with dedicated training in addiction, a social worker, Erin, and a nurse, Caitlin, and a rota of physicians that also work in the community as well as in the hospital, rotating each week. This service also provides phone consultations to providers and prescribers across the province in all healthcare settings. And it's made a huge difference. Our resident run service, I mentioned that we were doing it kind of after hours volunteer work for people who are already medical residents. It wasn't sustainable. And it really scaled back and basically shut down in part because a few of us had kids and couldn't do the extra hours anymore. And in part because we were actually threatened by some of the leadership in the mental health and addictions program that they were going to do college complaints against us because they said we were practicing outside the scope of educational licenses, even though all of our program directors were supportive. So at least the psychiatry residents all had to step away at that point, and the rest of us kept working for a little while longer under this weird threat. But now this new service has been really well received. It's incredibly busy, new consults every day, and just trying to keep up. So we've reached a new standard of care in terms of what we can offer in 2023. We've been doing, since 2018, tons of staff education initiatives, nursing education days and services, multidisciplinary rounds, speaking at grand rounds across all the medical departments. Much of the most powerful shared peer learning, I think, happens at the bedside in terms of the way that we can provide care to patients and how to think differently about substance use and harm reduction and getting people through their treatment and trying to help people feel safe and cared for in hospital. On at least many of our units, there's been a big culture change, even in terms of the language people are using, what gets documented in the chart. I've had some spontaneous feedback from some of the senior medical staff recently that they've noticed this as well. We're regularly offering short-acting opioids titrated to relieve withdrawal and pain. We've run into some trouble with injectable opioids. We don't have an injectable opiate agonist treatment program. And on some units, depending on the level of nursing training, we can't offer intravenous opioids. So patients would have tablets and then be crushing and injecting them in a hospital. Like I mentioned, there's no specific policies related to substance use, but there are some policies related to administering controlled medications like opioids in hospital. So on some units, patients have to pretend to put them in their mouth, even if we know they're not going to swallow them, which is, again, an institutional policy thing that's creating harm and creating new bacterial infections for patients that would be otherwise avoidable. We're regularly offering to initiate opiate agonist treatment in hospital with methadone, buprenorphine, slow release oral morphine, and to a limited degree, some of the prescribed safer supply. We have an amazing program in Halifax through Mobile Outreach Street Health, but unfortunately now it's full with a long waiting list. So we'll offer the short-acting opioids in hospital, and at this point now, people have to transition to regular kind of traditional opiate agonist treatment before discharge. The multidisciplinary addiction consult service, I mentioned, we've been through a complicated process of trying to hire a peer support worker that I thought was going to be done by the end of 2023. That's still ongoing. But we can invite community-based organizations to participate in care. So explicitly collaborating with Mainline and MOSH and other organizations to come in to the hospital to support people, even if we're not able to provide a peer support worker ourselves yet. We can do the take-home naloxone kits. We can offer sterile injecting equipment, at least sometimes, to some patients. We still don't have a dedicated space for patients to use in hospital, which creates some paradoxes and some where we're not able to provide the safest care. We regularly offer screening for STBVIs, and for some patients have initiated hepatitis C treatment in hospital before they're discharged, especially if they have to be in hospital for some time for intravenous antibiotics. So since 2018, so next steps. So since 2018, we've also had a process of harm reduction policy development. I know a parallel process has been going on in New Brunswick, and we've been learning from you guys along the way as well, and really appreciate it. It started with a multidisciplinary working group on the internal medicine ward. We've invited participation from people with lived experience at harm reduction organizations, mainly Morty and Joe from Mainline. We developed draft policy and standard operating procedures based on the circumstances that the nurses thought were most important for providing specific detailed direction around, and then did a focus group with clients at Mainline who had recently been in the hospital or were currently admitted to the hospital to get feedback on those situations, which I'll go into in a sec. And we're hoping this can be a model for province-wide policies. One of the leaders of our group is the health services manager on our internal medicine ward, Elisa, and she is continuing to try to elevate our draft policies to province-wide senior decision makers. And that process has been pretty stop and start. And as we've last heard, there's some legal review going on for the last 3 to 6 months or so about harm reduction policy directive in the hospital before specific policies can be developed. So as much as possible, these draft policies have been a resource in our hospital, and we've been sharing them around with all the other units to say, this is how we're navigating the current policy vacuum and how we're interpreting the policies that do exist in terms of what you can offer and how you can interpret these. And in general, each of these circumstances around different scenarios and substance use in the hospital recognizes that harm reduction policies are compassionate, patient-centered, evidence-based, promote human rights, and limit institutional liability. So they really should just be standard, non-controversial healthcare policies, because this is what we try to do for everybody. These are some of the specific scenarios that we're developing the nursing standards around: what to do when patients leave the ward and don't come back on time, what to do around sharp safety and distributing sterile injecting equipment, what to do when patients' own drugs are found in their bags or at the bedside, especially if the nurses or housekeeping are cleaning their room and come across things, what to do around PICC lines, or these indwelling deeper IVs for intravenous antibiotics, how to handle patients self-administering their controlled medications, which has been an ongoing struggle I mentioned, like with the tablets, and scheduling investigations, making sure that people have a clear idea about what's going on in their hospital care, so that they can make their own plans for the day. We've learned from other institutional responses. I know Dr. Catherine Dong speaking this afternoon, and we'll be able to share with you their experience from Edmonton. But just these examples that patients who use drugs have a right to receive high quality care, even if they're still continuing to use drugs. They have experience and expertise and should be directing their own care and should be involved in leadership and policy and care planning. And that harm reduction philosophies and care practices should be integrated across all of the health authority and all services. These are examples of supervised consumption sites. I know Catherine will share with you specific examples this afternoon. There's lots of different models and examples from other institutions about PICC lines and patients self-administering controlled substances in hospital. So we keep printing these off and bringing them to leadership and using them to develop our draft policies. So hopefully by 2028, at least some of these things will be in place. And this is the quality of care that I imagine we can deliver to this patient that I met back in 2015. Compassionate, culturally safe care that is consistent across all units. That's one of the real fears now, is that we can't promise patients as they go from one unit to another that the kind of care they receive and how they'll be treated will be the same. Every unit in our hospital is very different right now. Hospital policies and permanent funding to sustain all the things we've been talking about. People who use drugs supported to have leadership roles in care policy, design, and care delivery. In hospital supervised consumption services, including inhalation, respite housing for prolonged antibiotics with an option to transition to housing first, so we're not discharging people to encampments. Injectable opiate agonist treatment with liquid hydromorphone, safer supply options if that's what people want, to all to initiate in hospital and continue in the community without waiting lists. So this is kind of the dream for the equitable, high quality care we'd be able to provide within the next few years, building on what we've done so far. And then I just want to wrap up with some reflections on this process. Providing harm reduction care in the hospital in a medical environment with a medical perspective is not simple. I argue that it should be, but it's not, and it hasn't been, and that's why the status quo has been so bad. Patients with who use drugs, patients with substance use disorders, have needs and some behaviors, perhaps trauma responses and the idea of being stuck in hospital when they're incredibly sick, that are different than other patients we care for in acute care settings, and that healthcare providers have not necessarily been trained to recognize and address and support. So the basic education from the clinical perspective is something that we've been working on, and it's still not there in a lot of places. Healthcare providers bring their own experience and perspectives on substance use. Many healthcare providers, as I mentioned at the beginning, mean well, and people go into healthcare because they want to be helpers and healers. But people have their own perspectives and experiences on a substance use based on their personal experience, their family's experience, what they learned from wider society about abstinence and rehab and stigma. People who use drugs and healthcare providers have a mutual mistrust because of our systems and policies that encourage us to lie to one another. Patients who use drugs are expect to be punished and have their healthcare affected if they are disclosing substance use, which has been our institutional approach. So of course, we're telling people you have to lie to us. And then when trying to change policies and practices and culture, navigating care in relation to existing policies, or the gaps and lack of a policy. And this has been on both sides issues we've been coming up against in Nova Scotia, where there hasn't been a policy. That means certain care practices aren't empowered. And where there is a policy, it means certain care practices are restricted. And so we're trying to come up with, specific ways to interpret what's written, while we've been on this 6-year journey to develop new policies that actually make sense and are safe. But in general, not every patient should be treated the same, because not every patient has exactly the same needs. So for a group of people that are socially marginalized and excluded and have worse health outcomes, we argue that, of course, they need specific policies and services and programs in hospital for things to be equitable. So where to start? It takes an explicit commitment to equity and harm reduction and challenging the status quo. It takes recognizing that patients who use drugs are going to be continuing to use drugs in the hospital, and we can't pretend that they won't, and it's dangerous to assume that they can't. It takes support staff and teams to provide supplies for ongoing use, and eventually dedicated space for people to use drugs so that they're not having to leave hospital or hide. It requires working with community partners who are already experts in doing this work. It requires creating and clarifying policies and procedures all across the spectrum of people working at the hospital, including support staff, security, housekeeping, along with clinical staff. It requires unlearning, humility, engaging in ongoing dialogue and learning. It involves including people with lived and living experience in that learning and decision-making. I reflect on the fact that individual practice change is easier than system change. So even when there are policy restrictions, our status quo in terms of the quality of care that we offered was so poor that there were just individual clinical practice changes, like learning how to prescribe these medications, that we could do without changing the system. And we made a lot of ground there, and continuing to learn there and continuing to teach around that. So some of these changes are a lot easier than others. I'm also coming to the realization that I think what we were doing is illegal. And if there are people here with lived experience of being in hospital and have experienced health harms because of these policies, I'd encourage you to look into a human rights complaint. I don't think we have any active ones in Nova Scotia right now, but the law that does exist says that we can't treat people the way that we were treating people. The Canada Health Act guarantees universal access to health services in Canada, so we can't deny them to people just because they use drugs. Human rights law in every Canadian province recognizes substance use disorders as a protected class with a duty to accommodate. And as I've shared with you, it's really simple and straightforward and not costly to accommodate, to provide these harm reduction services in hospital. There's legal standards of basic patient safety and quality of care. And all of our provinces and health authorities are recognizing that harm reduction services are evidence-based, and they endorse and sometimes fund them in the community. And then when people come into hospital, we're restricting them, which is obviously not meeting the basic standard of care that's evidence-based, that the health authority acknowledges and the provincial governments acknowledge. And so there's an institutional liability that comes from restricting these harm reduction services. So I think there's a big legal case here that the poor quality of care that's harming people actually is illegal, and in hospital, and we may get there if policies aren't changing fast enough. So if there's senior decision makers on this call, I'd encourage you to be aware of this and potentially look into it. And if there's people with lived experience who have been harmed, I encourage you to think about human rights challenges. Just some resources for further learning for people. This is a wonderful review article in the International Journal of Drug Policy about hospital policy as harm reduction intervention for people who use drugs. And Duncan and John and I a few years ago wrote this one-pager in the Canadian Medical Association Journal on principles of caring for people who inject drugs when they are admitted. This really brief one-pager summarizes in large part this 100-page guidance document, which is wonderful and rich and detailed, that Catherine and her team in Edmonton led. That's also available free online. Amazing resource for people who aren't familiar with it yet. And then we have a national group focused on endocarditis care, and we did an online speaker series a couple years ago. This YouTube, still up on YouTube, this talk from Tally Cahill in Ottawa about harm reduction nursing in hospital for people who use drugs with endocarditis was particularly well received and has been particularly possible. And it addresses a lot of the things about like how would you provide good quality care even when you don't have a specialized addiction medicine consult service, and even when you don't have a dedicated supervised consumption site in hospital. Lots of practical tips, and we've been sharing it with everyone. And so to wrap up here, I just want to remind you the 3 key messages I was trying to communicate today. Hospitals should be partner with and learn from community-based organizations who are already doing this work. People who use drugs are experts in their own lives and should have leadership role in improving care and policies. And advocacy outside the system can be quicker, including individual practice change, but additional strategies are needed for sustainable change, both for policy and for practice. We need our whole institutions to be sustaining this work. And I encourage everyone not to discard one another. And this is my email. I'm happy to connect with anybody after as well, if it would be helpful.
Wow. Wow. Thanks so much, Dr. Brothers. That was a comprehensive presentation. Already we've had people ask if your slide deck might be available for them, but that was great. I understand some questions have come in. Nancy, are you able to connect the caller? Or
I am, yes. We do have a question from Tara O. So Andrew, just wondering if you could unmute Tara so she could speak or ask her question. Just so you know, Dr. Brothers, and thank you so much for that excellent presentation. Just a few comments. Somebody's asked if you would be able to share the slide presentation, if that's a possibility.
Oh yeah, definitely.
Great. And there was also a thank you from Debbie Warren about the recognition at the beginning of your presentation. So thank you for that. Lots of people clapping. I think that's not able to be seen. We have a couple of other questions. Tara, do you have your question? Are you able to unmute? We also have a question from Kelly, who has her hand raised. Andrew, if you're able to unmute, please.
Hi, can you hear me?
I can
hear you, Kelly. Go ahead. Hi. Yes.
Thank you. Thank you so much. That was absolutely wonderful and so comprehensive. My question is, what could individual healthcare workers, anybody, nurses, anybody working, what can they do to help further along these policy changes and these guidance documents to be implemented in their individual units or hospitals? Thank you.
Yeah, thanks very much. I appreciate that. And I think that, I've tried to share learning and lessons here kind of like with a wide lens, recognizing that there's people here that probably have all sorts of different jobs. And there's also going to be lots of different power dynamics in practice. So one thing I tell our medical students, for example, who are worried about speaking up and challenging their supervisors when they see poor quality care, that each individual across the whole spectrum, doesn't have to change the world and change the whole system and change their policies in the middle of the night on call. Just starting with like recognizing explicitly and saying out loud when we're not meeting the basic standards of care, and approaching people with kindness in a hostile setting, starting to do some of those basic clinical initiatives like that aren't currently restricted by policy, learning how to offer withdrawal management, learning how to initiate opiate agonist treatment in hospital for prescribers, and for nursing colleagues at the bedside, like you're the front line and spending so much more time with patients than the physicians do. So just trying to incorporate some of those harm reduction philosophies, care, compassion, and understanding at the bedside. And then for those who are involved in decision-making roles, obviously with lots more power, about trying to implement some policy change when it's not already there. But one of the most powerful pieces of advice I can give is to encourage people to get organized. A lot of people have some moral distress about recognizing this poor quality care, and in their position may feel powerless to change it. So start a group, start a meeting, start meeting regularly, build power, invite people from across the whole spectrum, invite people with lived experience. If you can pay them for their expertise from even smaller funding sources, please do so. But get organized, start meeting, start the conversations, and keep pushing.
Thank you so much. Thank you.
Thank you. Just something else, Dr. Brothers, in the Q&A, a thank you from Jacqueline McKinnon. Just wondering, you'd mentioned you were hoping to hire a peer support person, but it hasn't happened. What were the barriers to that happening?
Yeah, I haven't been personally involved in that process, so I can't really speak to specific details, but I am aware of some of the kind of general institutional issues. The hiring process was done through an organization that provides mental health peer support in mental health care settings in Nova Scotia, who apparently do really great work. And this a different setting of an acute care hospital that's like can be a hostile environment that's incredibly busy, that involves like a million different services and running around with not knowing who all the different services are at the teaching hospital, was just like shockingly different for this organization in terms of what they're used to doing and in terms of how they're used to providing support to people as they develop professionally in that role. So I think there's been a bit of a mismatch between kind of expectations and reality for this, and it just hasn't happened yet, partly because of that. Some of that realization happened quite late in the process. So my understanding is that they're trying to change their approach with a better understanding of the reality of the work environment, and trying again, basically.
Great, thank you for that. There's one other question in the Q&A from Eric, who is currently in Yellowknife. He is asking about, and wondering if it's okay to ask this here, but what's happening currently in BC. Just curious about, what we think what kind of bearing that may have on legalizing the use here without supports built in. Great question.
I might not completely understand the question in terms of the failure in quotation marks. If Eric can add a few more details, but I can just riff on this and reflect if it might be helpful. So the purpose of decriminalization is really just to reduce the exposure of people who use drugs to the criminal legal punishment system. And my understanding is that in many parts of BC that has in fact happened. And in other situations it hasn't, but to reduce the amount of policing and arrest and incarceration for people who use drugs. That's like the beginning and end purpose of decrim. And so in that sense, it hasn't really been a failure. Politically, there's quite a bit of pushback and blowback from this progressive policy change. It's being weaponized politically, which is horrific and unfortunate. So for example, most recently, there's been a lot of conservative op-eds and things about the danger of people using drugs in hospital. And it was heartening to see that the BC government's response is to say, yes, of course, using drugs in hospital can be dangerous unless we have the resources in place to do that. And so they are calling on all hospitals to have approaches to support people who use drugs in hospital safely, including supervised consumption services. So I don't think BC's been a failure that way in reality. I think the political contest is always going to be ongoing. And I think we just need to continue to push where we can.
Awesome. Thank you for that. Looks like that is the end of the questions unless there's somebody else who has a hand up. Tara, you didn't unmute yourself. I don't know if you still have a question or not. Oh. Sorry, I see one more here. Lots of thank yous and lots of clapping. We can't use the reaction mechanism. Thank you so much for your excellent presentation and your obvious compassion and passion and advocacy work on this topic. It's amazing. Thank you.
Well, thanks for having me, and thanks for all you folks are doing, and hopefully we can connect in person again sometime soon. But amazing turnout as well. Lots of familiar faces on the participant list. So hi, everybody.
Well, thanks again, Dr. Brothers. I think it's time for our first break. It was scheduled for 11:25, and we're a few minutes early, but that'll be fine. Let's reconvene at 11:45 for our first panel of the day. Thanks. Welcome back, everyone. It's time for our first panel discussion. We're joined by 4 panelists who will offer a local context and discuss overcoming barriers to implementing harm reduction services in Brunswick. Our first panelist is Dr. Timothy Christie, who is a philosopher and epidemiologist with a specialization in medical ethics. His research interests encompass the intersection of ethics in public policy and evidence-based decision-making. This would include harm reduction. He's the Regional Director of Ethics Services for Horizon Health Network. Before returning to New Brunswick in 2006, he was he's a healthcare ethicist for the British Columbia Centre for Excellence in HIV/AIDS at St. Paul's Hospital in Vancouver. In addition to his role as the Director of Ethics Services, he is an adjunct professor of bioethics at Dalhousie University and an adjunct professor of philosophy at UNB. Dr. Christie has taught medical ethics at the University of British Columbia, the University of Victoria, in Ottawa, the University of New Brunswick, Dalhousie University. We're also joined by Dr. Tracy Meyer, who is an emergency physician in St. John. She's interested in marginalized populations and addiction medicine with the mixed practice of emergency medicine in a substance use disorder clinic. He's an advocate for harm reduction in her department and throughout Horizon. We're also joined by Ann Patterson, who offered some great comments last night in a discussion of the film Love in the Time of Sentinel. Ann relocated to St. John last August. She was born and raised in Ontario and spent 7 years in Peterborough before heading east. While in Peterborough, they discovered their passion and love for harm reduction, an approach that provided them the tools to change and save their own life. While working on their recovery and wellness, Ann became deeply involved in street-level advocacy and anti-stigma work, supporting initiatives that aim to break down barriers to support, promote compassion, and reduce stigma. Transitioning from being a service user to becoming a service provider, Ann now focuses on helping others in accessing resources and breaking down barriers. Their story highlights the power of lived experience and community connection in overcoming challenges. Our final panelist is Holly Richards, who was a nurse manager for Ridgewood Addictions and Mental Health in St. John. She has spent her career fiercely advocating for advancements in harm reduction services in inpatient, corrections, community, and recovery settings. The word fiercely is an apt modifier. I've witnessed her contributions to the organizing committee of these symposiums over the years. Along with her academic credentials, she holds active certifications in both medical surgical nursing and psychiatric and mental health nursing. Holly volunteers with Sweet Team St. John and serves members of the community who live in encampments every Tuesday, providing a meal, essential survival supplies, and harm reduction items. She is an Avenue B board member with a keen interest in social justice and advocacy. If the panelists are ready, I'll offer each participant 5 minutes to present their experience on the topic of overcoming barriers to harm reduction. I'd like to start in the order that I presented the panelists. Dr. Christie, you're on.
Excellent. Well, thank you, Randy, for the introduction, and congratulations to the other panelists and the organizers. And thank you very much for inviting me to be a part of this panel. My comments are fairly brief because, as you know, panels are more about discussion with audience members than listening to our lectures. But the take-home message I want to give people is that systems are just a bunch of people. So when we talk about changing a system, what we really mean is changing the way people behave, the way people think, and the way people act. And this is totally doable. So for example, in New Brunswick, our problems are finite and we have solutions to our problems if we choose to solve them. So just as a little anecdote, I remember years ago, I was giving a talk in New Jersey on methadone treatment. And the person in charge of methadone for New York City asked me, she said, Dr. Christie, how many people do you think you have to get on methadone in New Brunswick to get a handle on your problem? And at that time I said, look, if we get 3,000 to 5,000 people on methadone, we'll be doing really, really well. She said, I have to get 300,000. So the magnitude of the problem she's facing is exorbitant. It's huge. It's astronomical. We don't have that problem in New Brunswick. We have only a limited number of homeless people. We will have just a limited number of people in hospitals who need nursing homes. We have a limited number of seniors. We have a limited number of people that have addictions. We have a limited number of people who need access to primary care. These all have solutions if we choose to do it. And like I said, I don't accept that systems are systems. I'm absolutely convinced systems are just a bunch of people. And if we can convince a few key people to make the right decision, then I think we can solve problems in New Brunswick without haste or without a delay. So basically from the harm reduction perspective, I work in a hospital, and in 2018, I wrote a policy called a harm reduction policy. And in 2024, it's still not approved. I think part of the problem with the policy is I use the word harm reduction. So, but the content of the policy is needle exchange in hospital. If you look at the scientific literature, needle exchange is an absolutely evidence-based intervention. So if you give someone a clean syringe and they use it, they will not get a virus from that. They're just not going to get HIV, Hep C, whatever. They're not going to get an infection from it. So it's just absolutely clear that you can prevent people from getting, say, bloodborne pathogens from a clean syringe. If you give them a sharps container and they put it in there, no one else is exposed to the needle. No one else is exposed to whatever is on that. So this is just absolutely clear in the literature that you can prevent harms from doing it. The literature is absolutely clear on supervised injection sites. So if a person is injecting an illegal drug under medical supervision, they will not die from it. So I did all the work on the first supervised injection site that we opened in Vancouver called Insight in 2003. And the evaluation for the first 3 years of the site, we had 3,000 overdoses in the site and no deaths. If you have 3,000 overdoses, say in a locked bathroom, what's your mortality rate going to be? Infinitely higher than 0. So once again, the literature is conclusive over 25 years that if you supervise an injection, the person's not going to die from an overdose. In addition to that, all the substitution therapies we have. So this includes methadone, Suboxone, the other ones, even opiates, prescription of opiates. The literature is clear that if you make it so someone doesn't have to prostitute themselves or commit crimes to buy their drugs, the benefits to that person are astronomical, but also the benefits to society. So there's no logical, rational, or evidence-based reason that we don't do these things. It is simply a bunch of people in positions of power who just won't do the right thing. So maybe I'll conclude my comments with that and pass it on to another panelist.
Thank you, Tim. Dr. Christie, do you want to, or Dr. Myers, do you want to jump in?
Yes, thank you very much. And I'd also like to express great gratitude for the people who put on this conference and thank those who are participating and thank those who were also attending and interested in these topics because they are incredibly important. I believe Tommy brothers did a fantastic discussion as well on what so many of these barriers are and how they've been working really hard in Halifax on approaching them. And we're going to be hearing more from Catherine Dong later today, hearing about what they've done. And I hope to learn as much as I can from both of them, because I think everywhere we can just learn so much from each other, and also how you manage these challenges. We were sort of given a few prompts as to what to talk about, and some of them are so difficult even when you look at the questions, as well as the fact that I think there's going to be a lot of redundancy in our answers, but that's okay because sometimes we have to hit the, we have to push the message. But when we talk about what so many of our barriers are, I really agree with Dr. Timothy Christie when he talks about policy is sometimes such a big barrier. And so, unfortunately, you often will see policies are used as they're almost used as a weapon. You'll hear, oh, that's against the policy. We can't do that. That's against the policy. And so sometimes when you're trying to change things or when you're trying to manage individualized care, generalized policy can be your enemy. But I think we can also make it our own weapon too. And in that sense, I think if we make our policies and have them very open, and what the biggest challenges, of course, is how do you make them open and considering all of the different aspects that they can be. But I do think that that's where things can happen. But it is also some of our biggest challenges. When I look at what we do see in some of the areas where I've seen really significant structural stigma, I've been in St. John for 7 years, and the amount of change that has happened in those 7 years has been astronomical. And there's been changes in so many ways. When I first moved here, if you asked me if we needed injection sites, if we needed to have like supervised injection sites or the injection opioid agonist therapy program, I absolutely would have said no, because that wasn't an issue 7 years ago. And now I'm the clinical lead for an injection opioid agonist therapy here in St. John. So obviously I've completely come a 180 on this discussion, and it's not because of my own opinions, it's because of what the culture is out there. And so when you see so much cultural change in actually a fairly significant period of time, that's a big difference. So the rate of dangerous supply out there has changed so dramatically in the last few years, and it's something that we started seeing in 2020 with COVID. The influx of fentanyl, the influx of other agents, large amounts of benzodiazepines mixed into the opioids. All of a sudden, we started having all of these overdoses that we really weren't experiencing in New Brunswick prior to that. We were almost like this little happy microcosm in Canada with us in Nova Scotia and the rest of the Atlantic provinces, where our substances were really prescription opioids. People were using Dilaudid on a regular basis. People were using Percocets. We didn't have heroin here. If heroin was in the city, it was a patient would actually come to me and say, like, I'm worried. I heard there was some heroin. Somebody was using some heroin the other day, and it was usually just somebody brought some with them in their suitcase when after they were visiting friends out west. But it was actually something that the patients came to me saying that they were worried about the fact that the heroin was present. And the amount that has changed in the last few years with the influx of fentanyl. And so 5 years ago, we didn't have anywhere near the number of overdoses. We had large amounts of infection. We had issues with endocarditis, but we didn't have the overdoses because an 8 milligram Dilaudid was an 8 milligram Dilaudid. And so the overdoses were situations where people were injecting when they were using like after a period of abstinence or using after a period of coming out of hospital. But now we're starting to see such a massive increase in injection. So that's one major thing that has changed in the last several years. But the other thing that has really changed is we have seen a big movement towards harm reduction within the community. And I think that is something that we've responded to the changes in what is out there and and what we're seeing in the community. And I think that is a big improvement. I think there's definitely things that we could improve upon, as was mentioned. We can make these policies, but getting them through all the different levels can be challenging. But I would say that even in the last 7 years, seeing the the stigma that was present within the hospitals and seeing how that has gradually changed. I think there's still lots of improvements. And when you see that some floors are very comfortable at giving out safe injection supplies and other floors are not, those are things where our own policies would be able to make a change for the better, where we can show that if it's done in one place, it can be done in all of the different locations within the hospital. Some of the things that I've seen really improved change, again, where you make a policy, sometimes that can actually be so much for the better because it improves physicians' comfort level and nurses' comfort level. One of the things that we have seen is we recently made a clinical order set for injection opioid agonist therapy within the hospital. And within even just, I would say, days of that becoming going live, I could see I had a patient who was admitted, and all of a sudden they were admitted to family medicine, and the family medicine physician was actually comfortable ordering the prescription of 70 milligrams of hydromorphone injection for this person. And because there was a clinical order set, they had that comfort level with it because they were able to, there's all of the aspects built into it, all of the cautions, all of the safety components, the opioid sedation scale is built into it, the naloxone dosing is built into it, as well as having the pharmacist on board phoning the clinic and the pharmacy in the community to make sure that the doses were correct. And so having that type of stuff built in does create a certain level of comfort. And so again, I think policies can be detrimental, but they can also be incredibly beneficial for us as well. When I think of major barriers that we are coming across, it's so much of the barriers are about the issues of when you're admitted to the hospital, becomes a major part of the fact that you're kind of locked into that room. And so within COVID, we had the issues with the fact that people weren't actually able to leave the hospital. And so all of a sudden they were trying to, if they were trying to use or get their supplies, that was a major issue because they weren't able to, that they were signing out at a higher rate simply because they weren't able to access what they would normally get in the community. But one thing that we do need to consider is also when you start looking at individual people, you realize not everybody uses the same way. And so a lot of our patients actually smoke their fentanyl or smoke their stimulants. And I think that's one area where we do need to start looking in our policies and looking in our harm reduction. Is we can't keep saying that, you know, we have this opportunity for injection. And I think having harm reduction and having safe injection sites is fantastic, especially in a hospital. But when you start looking at how many people smoke their substances, how are they going to be able to do that in a hospital that has a no smoking policy? And so these are things that we just have to keep having a bit of a different mindset and different ways of approaching the issues. So those were sort of my thoughts on the process. And as Tim mentioned, a lot of these panels are really about the discussion that happens with the questions. So I'll move on to the next person, and I look forward to your comments and I look forward to the questions. Thank you.
Thank you. Em, do you want to take a turn?
Hi, thank you for having me here today. I come from a lens of lived experience. My first thoughts on overcoming barriers to harm reduction. The biggest barrier, of course, there are so many, but the biggest barrier to harm reduction that I've both seen and experienced, both as a service user and now in a service provider position, has been stigma. And of course, stigma influences the decisions that people in power make. And I think I really appreciated and agree with what Dr. Timothy was saying about how we're all people. The information is out there, the evidence is out there, and the expertise and the experiences, like, they're out there. But it's a matter of bringing everyone everyone to the table, so that we can see and hear those experiences, and the things that have helped to change. I also want to mention that, even in terms of policy work, policy changes are so beneficial. And there's been some positive change in that. But there needs to be a cultural shift as well, in terms of respecting and honoring the places that people are at. This is also, I'll also share, this is my first time being a panel speaker. So thank you for having me. I will pass it on to the next person. I'm looking forward to the discussion. Thank you.
Holly, next.
Thanks.
Seriously engage in this conversation.
So I'm bringing a unique perspective. So I started my career as a registered nurse on 4C North, and what drew me to work on the internal medicine unit at the regional hospital was the unofficial needle exchange policy that existed, because as a student, I had a keen interest in harm reduction. So from there, I've always loved harm reduction. I would say harm reduction is probably my professional purpose. I'm a huge advocate, and my whole career has been wrapped around advocating for people who use substances, and fighting against the stigma and the misassumptions around people who use substances and all the things. So, and then I had the opportunity to go into corrections, and I know corrections is an inpatient hospital setting. However, the correctional setting is definitely overpopulated with people who use substances. It's a very criminalized medical disorder, and a lot of people find themselves incarcerated inappropriately, in my opinion. And harm reduction policies are severely lacking in the incarcerated setting. So I do bring that lens with me as well. And currently, as Randy had mentioned, I'm the nurse manager at Ridgewood Addictions and Mental Health. So that's inpatient detox, inpatient concurrent rehab, and inpatient early recovery, so the Horizon Recovery Center. So I think it would be amiss not to include this setting in the discussion as well, because harm reduction is important to practice in the recovery setting as well. So those are kind of my 3 viewpoints that I'm bringing into the discussion. And then I do street outreach every week, and that is a whole other kind of piece to the pie. So I really see folks who use substances in different levels of the continuum of care. And I want to bring all those different perspectives, and I'm looking forward to the discussion. So I don't want to give any of my answers away for the question, so I'm going to hang on to them. But I do want to make one point that hasn't been made yet that I think is really important. And it doesn't matter where you're working, it doesn't matter what your role is, taking the time to establish trust with your patients who are people who use substances is important, because of the stigma, I think. And I mean, correct me, like you are the expert as a former service user. So I will definitely default if I'm wrong, but I think it's important as a service provider to really take the time to establish trusting relationships with folks who use substances, so that they're comfortable including you as partners in their care. And it doesn't matter if you're in the hospital setting, it doesn't matter if you're in the recovery setting, it doesn't matter if it's in the incarcerated setting or in the community setting. Building that relationship and taking that time is an integral component to working with people who use substances. So I'll leave it at that.
Thanks, Holly. I'll remind our participants, or those that are joining us today, that you have an opportunity to ask questions directly. You can raise your hand, and I know that Nancy will stand by and connect you to the panelists.
We do have a hand raised, Randy. I was just going to say, so Andrew, if you could unmute and I'm gonna try to say your name, Murad, if you would like to unmute and ask your question, go ahead.
Yes, good morning, everybody. My name is Mohad, and I'm a senior program advisor for the North region for the New Brunswick. I work with Dr. Gad. I have a big question about the safe injection site. And one of my biggest file is the harm reduction. And I am looking across everywhere, like for example, Montreal, Toronto, like when you look everywhere where we install a safe injection site, you will realize like after a couple weeks, like all like the surrounding of that area get I'm not gonna say destroyed, but like have like it get weird or difficult. For example, in Montreal, they install a safe injection site in one neighborhood, and a couple weeks after, like it become really bad for the residents who is living there. I am a big fan and for the harm reduction philosophy, and I believe like us being a health professional, we need to respect equity for all the population. But how can we do to, if you have the solution to that question is, how can we do to be able to install a safe injection site in in areas without impacting people who is living negatively, people who is living in that area? Thank you very much.
Thanks for the question. I'm not sure if there's any panelists that wants to tackle that one directly. If so, perhaps you could just sort of raise your hand so I know that you'll be the person that I'll call on.
I can't see where to raise my hand here, Randy.
Okay, I hear you, Tim. Go right ahead.
Yeah, so I just put in the chat a link to a paper that was published in 2004 when we opened the first supervised injection site in Vancouver. And it showed the opposite results. There was no public disorder associated with opening of the site. And it showed that there was actually benefits to the community of opening it. And this is the same argument we had with needle exchange years ago, that if you open a needle exchange program, people are going to be hanging around. They're going to be visibly, disruptive and that type of thing. And I think that the point is people are where they are. So right now, I don't think a supervised injection site in St. John would make more of a mess than we have in Waterloo Village right now. I don't see how a site could do anything. So we have people where they are. They're members of our community. They have a right to be there. They're part of us. So I'm not sure that it's true that opening of sites have a corresponding community disorder. But if they do, there's easy ways to clean up communities. But I see Em found how to raise her hand, so I'll stop.
Go ahead, Em.
There we go. Yeah, I raised my hand because I agree so fully that and I do want to validate the concern that comes with that can come with these things. But I think it's worth noting that, yeah, like there are people around who are using anyways, and we see them. We see that there are areas with more folks. We see folks around the community, no matter what neighborhood you may be in. And I think it's worth acknowledging too, whether does bringing in supports such as like a safe injection site, does that increase or decrease safety, or does it potentially just decrease some comfort by seeing people, by seeing how many people need to access these services? I think it's really worth kind of looking at, yeah, is it unsafe or is it uncomfortable?
We do have a comment from the chat as well. Thanks for that, Em. From Deborah Warren, that it can be manageable with adequate supports if it's, we take it takes a village to assist Ensemble with its site. Good point, Debbie. Yeah.
I'd like to follow up with one of your comments of yours, which addressed the issue of scale and how the numbers would suggest that these challenges aren't insurmountable in New Brunswick. At the same time, that scale, I think, affects the number of folks that are actually working on the files, whether it's medical practitioners or those providing wraparound supports or doing street outreach. Now, what's it going to take in New Brunswick with a population of, on a good day, 850,000 to actually bring about a systems change? And I say that because I think, you know, New Brunswick is the only province without a dominant urban area. We lack an HRM, where you have a provincial capital with federal presence, regional head offices, lots of universities, and 500,000 people. As Debbie Warren, as Julie Dingwell, and others in Fredericton would know, we have 3 principal cities and none has more than 80,000 people. So we have all the challenges of a big city and a small city. And just creating and maintaining the continuum of support is a huge challenge for us. And I often wonder about scale and how, with our size and our dispersed population, we can bring about a systems change. So I would challenge any of the panelists to try to address that scale question. Is it a blessing or a burden?
I guess I would like to just start by saying it certainly is a bit of a challenge. And even though we don't have a single one major site, even further to that, I would say one of the issues that we even have here just within St. John is it does feel like there's a lot of people working in silos with unfortunately very little discussion between them at times. And so it does seem like there's very little over planning within the greater New Brunswick, but even within St. John itself. And I think that is something that we could do some really major changes in, because if we want to look at policy changes and if we want to look at especially changes within the inpatient management, we really do need to have better communication across all of the hospitals and all of the major communities and all of the different players and all of that. You mentioned the fact that we have 3 urban centers, but when you look at New Brunswick, some of the significant issues that we have in New Brunswick is actually not even the urban centers, it's the rural issue. We have such a huge rural population. And when you start getting into the rural challenges, you have all of the more issues with access to care amongst rural people, access to safe supply, safe there are issues with even access to opioid agonist therapy with transportation. And so when you start looking at some of the challenges within New Brunswick, we have to also consider the fact that there's that large rural population as well.
I think Tim's hand was up first, but I'm going to go because I haven't had a chance to speak yet. I kind of wanted to have a little bit of a conversation and bring it back to inpatient, because I think talking about safe consumption areas in the hospital setting is something that's truly lacking really in New Brunswick, and I'm sure in a lot of the maritime setting, as we learned this morning with Tommy's presentation. And my experience working on 4C North historically and currently, because I still do pick up there on a regular basis, is we do give sterile injecting supplies and do safer using teaching with people who use substances when required with our inpatients. And currently there isn't a safe space for them to use the substances. So we do discourage use in somebody's bed as part of the policy that does exist, the unofficial policy, because of the risk for sharps. And there's a sharps container in every room in the hospital or on that floor on 4C North. However, what I find is that people are either going outside to use substances or they're using substances in the bathroom, which is concerning for many reasons. We in the community setting, we're always talking to people how important it is not to use alone. and to have the lock zone and all the things. And in the hospital setting, there isn't a safe space for people to use. So, and I think similar to maybe the public discomfort in the community setting, it's, you know, the senior leaders and like maybe some of the staff that aren't up to date on harm reduction research, and the discomfort, as Em said, I love that, the discomfort around having a safe injection site in the hospital setting might be some of the barriers to having that implemented, but it's such a service that's needed. And I would love to hear Tim and Dr. Mayer's perspectives on that specifically, just from like an inpatient setting, because I wish as a Forest North frontline nurse that I could send my patients somewhere safe to use their substance of choice with sterile injecting equipment, knowing that naloxone's on hand, knowing that there's somebody available in case they should take a little bit too much that time. So yeah, what do you guys think about that?
Em has her hand up, so I'm going to defer to her.
You're on mute, Em.
Thank you. Keep catching myself. Yeah, I just wanted to agree quickly with what Holly was saying. And also I wanted to very quickly bring back a point that Dr. Tracy Myers mentioned earlier as well, about how there's such a need of support for those who smoke their drugs as well. Of course, that adds, there's so much complexity in terms of logistics for inside sites. But I just kind of wanted to mention that point as well, to keep that in mind.
Great. We do
So-
have some questions in the Q&A. One from Jean-Sebastien Arsenault. How can we in small rural areas try to bring more harm reduction community initiatives to our region? Some similar things to what we see with Ensemble in Moncton. Where do we start? That's a big question.
Maybe I'll just jump in and carry on the conversation from where it's going right now, but a few things. So first, the hospital doesn't need a supervised injection site. We supervise injections all the time. How many people do we give pain medication to? And we look at them every Q15. We do this constantly, regularly. It's not something that's foreign to us. So patients don't need a place to go. They just need to be able to do whatever they're going to do, where they're going to do it. And there used to be a time, and most of you are too young to remember this, but Randy might remember with me, we had what they call smoking rooms and smoking sections. And sometimes when someone smoked something, you open the friggin' window. And it wasn't the end of the world that these things happened. So we are absolutely insane right now with our smoke-free policies. And there's very problematic. So if someone's going to smoke crack, you open the window, blow it out the window, light your cigarette, light your match. It's not the end of the world. We behave like it is, but I can assure you, for decades when I was younger, we did it without any problem. But and then with Randy's point about scale, one of the things I want to say is that I hear that we're small towns with big city problems. But if you look at it, we might have 1,000 homeless people in St. John, another 1,000 in Moncton, another 1,000 or so in Fredericton. We have a $9 billion budget in this province if we prioritize the social determinants of health. Because right now in Horizon, for instance, we spend $1.4 billion on hospitals and doctors. We need to do that. But everyone knows that medically necessary hospital and doctor services account for about 25% of the health of the population, and social determinants of health account for another 75%. We don't invest 1.4 billion in the social determinants of health. So if people had a right to the social determinants of health, the way they have a right to medically necessary hospital and doctor services, we could revolutionize our communities. And like I said, we have a finite number of problems. We have a finite number of people, and we spend a lot of money in the wrong place. So I hear that we're small towns with big city problems, but we have budgets to accommodate that.
Dr. Myers, you had your hand up. Do you want to go ahead?
So just as a couple comments to that, because I absolutely agree that when you start looking at the social determinants of health, I mean, when people talk about what are the biggest barriers and what are the biggest challenges with people who use drugs at the moment, it's not these substances themselves right now. I think the biggest barrier and the biggest challenge that we've seen within the last few years has been the massive boom in the homeless population and the challenges with housing. And I know that's going to be this afternoon's discussion, and I'll leave all of that to them. But I do agree wholeheartedly that we can't solve substance use, and we can't solve the dangers of substance use without dealing with the with all the aspects leading up to it, which unfortunately is really the other aspects that are not being managed at the moment as well. And it's just gone through the roof. When we start looking at hospital management, when we start looking at inpatient safe injection and of substances, we do, that is something that we don't currently have here in New Brunswick. And I agree that there's certainly different ways we can look at it. Is it that we need a safe injection site, or is it that we just need people to be safe where they inject, no matter where that is? And there's different discussions about having naloxone kits readily available to all patients and making sure that they know that if we remove the stigma of their use, they can actually call the nurse and say, hey, I'm about to inject, can you check on me in 5 minutes? And if you take away the barriers and the stigma of that person injecting, they no longer have to fear telling the nurse that they're going to do that. And all of a sudden they can use the nurse as their friend, as their person who's watching over them. And so I think so much of that is more to do with policy, not policy change, but culture change within the hospitals. And so that if you have it where patients see the health care practitioners as being part of the solution and part of their care team, and not somebody who's going to tattle on them or take away their substances or take away their rig, then all of a sudden they're going to be using that person more as someone who's going to be helping them with that. I think with the introduction of the IOT program within the hospital, that's obviously only a very small percentage of the people that are coming in who use substances. We only have about 47 people in the program currently. So as you can imagine, it's a very small number who end up in the hospitals, and that's specifically here in St. John. But what you see with that is you are starting to see nurses seeing, oh, this is the quantity that people actually inject. And so as they see that, they can actually become more comfortable with those numbers and become more comfortable with knowing, okay, when somebody injects even a large quantity of hydromorphone, they are walking and talking and acting like a normal person afterwards. And so when they recognize that that is actually something that they're able to do, it takes away some of the fear of having them inject on the floor as well. So I do think that we've made a lot of strides, but I think some of the biggest change is going to be in the culture change of the healthcare practitioners.
I'm gonna add on to that from the perspective of a registered nurse working in a completely broken healthcare system right now, because I disagree with you, Tim. We do need a service, in my opinion, and I'm going to explain the reasons why. And I am the least stigmatizing person. And when I am working with somebody on Forest North and I know they're using substances, I do check on them. But you have to think of the rest of the population of Forest North. You have to think of the staffing. And it's not just as easy as doing Q15 checks when you have 7 internal medicine patients and you have somebody pre-coding, because basically it's like a step down unit staffed like a medicine unit. And there's like, I don't have capacity to be like hanging a high risk transfusion here, dealing with somebody with problematic hypotension here, and then ensuring I do Q15-minute checks on this person here. Like, it's not structurally possible. So talking about those structural barriers to implementing a practice, that's a great policy. We can put that in writing all day long. And I agree with Dr. Mayers, attitudes need to change throughout the hospital, 100%. Attitudes need to change. That's not going to fix the nursing crisis. So there's just not enough of us to do that. So because there's not enough of us to do that, I think having a service where that is the purpose of the service, there is a safe space for that person to go. I think that is a solution that is worth being explored for those reasons. And I don't think the staffing, like the nursing crisis, is going to be fixed anytime soon. And the other point I wanted to bring up about like the hospital policies and systems, and the biggest barrier I see to seeing harm reduction flow seamlessly across all transitions of care, like looking at it from all these different lenses, is the way it's structured. We have these two pillars. We have inpatient acute care. We have community addictions and mental health, which also has some inpatient services. And they're two completely separate entities, and it doesn't overlap the way it really should for this population, because people who use substances really hit every single aspect of healthcare, right from, you know, long-term care to surgery to neuro to internal med, and then to detox to rehab to community to the, like, you know, IO to all the things. And I just don't feel like there is, you know, like a constant flow of information between these two entities in the program. So how do we work together better? And is there a role, like what I would love to see happen is for there to be some type of role developed. So I'm going to pitch it. So if there was like a harm reduction clinical nurse specialist that didn't belong to a portfolio, who could help somebody through their stages of care. You have somebody admitted to neuro, they need a short-term antibiotic, they're going to leave AMA. So currently these folks do leave AMA, but what if we could say, we're going to connect you with our like community, you know, our harm reduction CNS. They're going to connect you with community, make sure you get your IV antibiotics that you need, whether it's connected with IV day or IV days brought to them, because that's ultimately what harm reduction is meeting people where they're at, and maybe where they're at doesn't want to be in the in-hospital setting and wants to be in the community setting. So how do we bring care to them in those appropriate settings? Same thing with us. We have here at rehab, you know, we have somebody with acute medical needs. Right? I'm an inpatient unit. I'm considered inpatient horizon. I have to send my people through Emerge to get care. There's no like streamline where I can just say, my inpatient needs this service over on this. I have to go all the way through the back door. And why? Why is it that hard? Anyway, I'm going to jump off my soapbox, but those are some comments that I wanted to throw out there.
There are several comments in the Q&A, Holly, that do support, you know, those who are on the nursing units that are supporting exactly what you're saying. I'm wondering if we can unmute Andrea Ann. She has somebody has a question, please. And Andrea, go ahead.
Good afternoon, everyone. Thank you. This has been a wealth of information so far. And I guess I have a question because a lot of this content is new to me. When you're talking about safe injection sites in hospitals or the what you described, Dr. Christie, as well as maybe being an alternative, the individuals that are users, where is their supply coming from? Are they bringing in their own supply? Does the hospital supply that for them? What does that look like?
They bring in their own supply on 4C North. So from like an inpatient perspective on 4C North, people are, if they have their own supply, we say, do you need sterile syringes? Do you need cookers? Do you need alcohol swabs, filters? We give them what they need with the understanding that they have their own supply. I wish we could give them a safe supply, but that policy that Tim drafted 6 years ago is still in the queue.
I guess that layer provides an extra strain on anything because of what was mentioned earlier with the unsafe supply that's out there. So you're there to support, but from the service provider side, not knowing, I can't imagine living in that world of trying to support someone, but you don't even really know what you're dealing with while you're trying to help support them at the same time, I guess.
they're going to use it anyway. So at least
Yeah.
providing them with sterile, building that trust that I talked about earlier, and providing them with the sterile supplies to use safely and opening up that dialogue. The hope is that, and I say, like, let me know when you plan to use that and I will check on you. And if I can't check on them, I send a PCA or one of my partners on the floor to check on them. And that's the best way we can ensure safety.
Thank you so much, Holly.
Do any of the other panelists have anything to add to that answer?
Yeah, I just wanted to pop on and support what Holly said about the importance of building those relationships with the patients. Because yeah, in building those relationships with patients too, not only is the patient more likely to disclose if or when they're about to use, but then there's also the ability to have conversation about what they're using. They may disclose and say, yeah, I know my friend used this the other day and they thought that it had some benzos in it, so I don't know, it might, like, the dialogue and the conversation is so valuable and so important. And to not be afraid to share is huge.
And maybe I'll just jump in on that and say, years ago when I was working in Vancouver, we expanded access to methadone by 10,000 spots in 1 year. And the way we did it was by decentralizing it and integrating it into primary care. And likewise with needle exchange, when we had a crack epidemic, we had to go from distributing 3.5 million needles a year to 12 million needles a year. We couldn't do that through a centralized location. So what I've learned over the years is you can't let perfection be the enemy of the good. So you can have an ideal way of delivering a service, but that doesn't absolve us of our responsibility now to integrate these things into practice. So I fully hear what Holly's saying about the stresses we have with our frontline people in the hospital, but this is still a standard of care. This is still a practice. And the scientific literature is absolutely conclusive on these issues. So notwithstanding the fact that we don't have, say, a supervised injection site in the hospital, doesn't mean that we shouldn't be supervising injections right now. Starting this moment, we have the expertise, the skills, the knowledge, and the evidence to support it. And of course, we should always be advocating for more, but we can't let the fact that we don't have those dedicated resources make us think we don't have an obligation to do things now.
I'm just going to jump in and say I agree, and I do that in my everyday practice. So I'm not saying that I don't agree that as a bedside nurse, we shouldn't be, supervising when able and building those relationships. I'm just saying there is a personnel issue there, and there are going to be times when somebody is going to use their substances alone and they're going to use unsafely because the nurse isn't available to be that person for them in that moment, and that's going to happen more times than not. So starting to plan something that's actually like sustainable and feasible and will work 100% of the time and not just a portion of the time is important. I just wouldn't want to delay the work in considering having that type of service, because this is something we should be doing anyway, because it's not something that's happening. And I think we all need to change our attitudes, but we're not going to change the staffing crisis. So we're not going to be able to meet those needs from a personnel perspective. So let's start thinking about solutions that would meet those needs. And it's just the nurses doing it just as part of their everyday care. It's not a solution, I think, that's sustainable.
Go ahead, Dr. Myers.
I just
It's
wanted
very
to
complex.
It is incredibly complex. And when you look at personnel issues, it is such a massive challenge right now. And I think that is something that it's really useful. This is why it's so useful to have people on a panel from all different aspects of the care, because we can have so many discussions around it and also have the different insights of everybody. And I think sometimes having these types of discussions is how you end up brainstorming different solutions. And there is not going to be one solution that's going to work well. I mean, at least not for a while, because obviously having more nurses would be wonderful. Having an actual set safe injection site would be great. But these are all things that take time. And when we're dealing with something that's happening at this very moment, it can be difficult. The other things that I think about is, and I don't have the name of it at the moment, but there is actually the phone line where you can do safe injection over the phone. And so even just having the card of that available to the patients in the little brown bag that we offer them and saying, we know that you might be injecting while you're here. And if you don't have a friend with you and if you don't feel comfortable calling for the nurse, you can use this phone line and that person will sit on the phone with you while you inject. And they can call for help for you if you don't respond within a set period of time. And so there are all of these different aspects of ways that we can kind of keep an open mind and also have different options available. But I do agree that having something a little bit more set in stone would be incredibly useful.
Also a great point in the chat. Is there a role for peer support to assist in this situation? That's another possibility. No
I think
worries.
Em was had her hand up to say something there.
Go ahead, Em.
I was actually, so I was when Dr. Tracy Myers brought up the phone service that is available for those who use, who they can call in and use and have someone over the phone with them. It made me start to think more about the question about how to bring more harm reduction community initiatives in smaller rural areas. And I just kind of wanted to mention that, that's such a good question, and it's such a hard question to answer because there's a lack of resources, but there's not a lack of people. There's not a lack of people, and there's not a lack of people with experiences. And I think it would be worth seeing if there's ability to have community discussions, both with people who are actively using, people who are in recovery, and whatever resources are available around. And again, to listen to all voices about what may be needed, and then to figure out how you can support on a community-based level.
Excellent point, for sure.
And if before
go
you
ahead.
go, just to build on what Em was saying, and that those two big silos that I was kind of mentioning, like, why can't we take that conversation, what's available for community support, and pull it into the inpatient world? And blend them, just like Dr. Mayers had said, why not use that? And I think that's brilliant. That's a great solution, like quick solution to a problem that could be implemented tomorrow on 4C North. And I honestly might email like one of the educators or some of my contacts and just say, FYI, this is a great idea. Have you thought of this? Because that is brilliant. Why not give people the Norse, I can't remember what the acronym stands for. Why not give them that info so that they can make that phone call? So just taking some of those community initiatives and looking at how they can be implemented in an inpatient setting. So great point, Em.
Go ahead, Em.
I did have another thought that popped up as Holly was speaking, but then I got excited in agreeing with what Holly was saying, and now it's left my mind again. Let me think for a moment. But it was a bit of an example about like how like community-based like initiatives can kind of start. And so like, for example, in Peterborough, something that we noticed was, of course, there's a toxic drug supply, and it's constantly changing. And we noticed that there was in the community, and speaking to folks who are still actively using, the group that I was working with, we did our best to let people know when there seemed to be an influx of overdoses. But folks were giving us feedback saying that they weren't finding out fast enough. How can we figure out how to do that better? And we were able to come up with a community kind of system of when someone uses, and it was a bad drug or bad experience, to text one of us. So then in our individual interactions with folks, we can relay that information, again, not through a, like, for lack of better wording, a big fancy system, but just through having each other's backs, and through just having really open communication of like, hey, I used this drug, it was this color, and this is what happened. And then being able to share that information with others. And that's something that can happen in smaller rural areas, is that community discussion and yeah, being able to be open about it is huge.
Excellent point, for sure. There is a question in the Q&A from somebody who is in New Jersey in the US. Are we seeing xylazine wounds? If so, is wound care being provided in street outreaches and in harm reduction sites? Is anybody aware of this is another big question, a withdrawal protocol? Anybody want to tackle that one?
I will just say I saw that question, and so to be completely honest, I had to Google xylazine wounds because it isn't something that we've seen too much here. Maybe Holly or Em can say otherwise if we are starting to see more of it, but I haven't seen it within my own population of clients and patients. So thankfully we haven't seen that very much, but we do have in some of our locations, we do have wound care that is provided. So at Recap and Riverstone, there we do have LPNs who will provide wound care for our patient population, but that doesn't reach out to all other people within the community. So we have people who do wonderful nursing, like Holly. So I'd like to hear her opinion on this.
I haven't seen any specific wounds from that substance either. I don't have any specialized knowledge on that, but from a wound care perspective, the street team SJ here locally is equipped with first aid kits, and we do wound care in the encampments. My team is equipped with 2 registered nurses, a human service counselor, and a med student. So that's the Tuesday team. Not everybody has medical background though, so it is only basic first aid typically that we do provide, but because our team does have a little bit more advanced knowledge, we're able to give advice based on, you know, our expertise. And we have collaborated with some physicians and we're able to get people connected with community clinics when needed and things like that. So there's been some amazing collaborations happen between some of the community organizations and physicians in our team, and just getting people the care they need. Stigma is huge. A lot of people, there's been, you know, from like a camp perspective, I've had people like they're preparing for a storm and they have this abscess on their neck and they can't access Emerge because they have to prep their camp for the storm that's coming. So there's been that. And then there's been, you know, my partner is in danger, so I can't stay in Emerge. And then there's always the stigma piece that has come up with the people that we speak with. So it is challenging, and I worry about my folks a lot. You really get to know these folks when you see them once a week for, you know, every single week. And I do genuinely worry about them. So there's lots of barriers to accessing emergency care. I'm super grateful that Dr. Mayers is the face of Emerge sometimes, because that is a welcoming face for our folks. And I'm so super grateful for that. I know a lot of people access St. Joe's and it's not always as welcoming, but yeah, we do wound care in the field for sure.
Just an interesting point. Thanks, Holly. And your compassion certainly shows for sure. Deborah Warren is saying that 10% of substances tested since January at Ensemble contain xylazine. So just evidence of how this is ever changing every day. It's hard to stay on top of for sure. Em, I think, did you have a comment or something to add?
Yeah, I just kind of wanted to mention that I, since moving to New Brunswick, I haven't had many interactions or experiences with xylazine or xylazine wounds. But I do just kind of want to mention that it was something that we were seeing very frequently in Peterborough as I was moving, and in supporting folks with xylazine wounds in Peterborough, we did notice that it was they presented much differently. And I think so just kind of stressing the need for a proactive approach rather than a reactive in all areas of harm reduction is super important, especially as xylazine inevitably will have more of a presence.
Excellent point. And Avenue B is saying the same thing, that they're also seeing positive tests for xylazine. I want to acknowledge in the Q&A that there's, lots of comments about, and people maybe can go back and have a look, but lots of comments about the debate of access to harm reduction on every unit, every nursing unit, as opposed to, the having a specific harm reduction unit. And, certainly the arguments can be seen absolutely from both sides. Is it more stigmatizing to place everybody together in one spot, et cetera, et cetera? All really good points for sure.
I think it's important to know too that if we did have a safe injection space in a hospital setting, that doesn't mean that people need to use that space. It just means that it's an option for them. It doesn't mean that people can't use in the other spaces that they do so now and that we won't support them. It's just giving an option, right? It wouldn't be like you have to use the space because it's been developed for you to use. I think it's just giving people, like, we know you use substances and you deserve a safe space to use. Here it is. If you choose to use it, it's your choice. Yeah. Like, I think that's important to have that.
The approach certainly, and how it's worded certainly makes a difference for sure. Absolutely. Go ahead, Em. Did you have something?
Yeah, I wanted to support what Holly just said about the element of choice is so important. Yeah.
Somebody has added a link to xylazine wounds in the chat, so if you want to check that out. Any other questions from the attendees or in the Q&A? There were lots of thanks, and lots of comments about your t-shirt. And I'd like to, and I think Holly has hers on. I have mine on today as well. I'd just like to mention those were donated to the committee, but from Mom Stop the Harm, another really important organization with regard to this whole subject for sure. So thanks to Mom Stop the Harm.
In the meantime, as we wind down, I would ask each of the panelists perhaps to leave us with a final thought or a final comment. And we're talking about the barriers to harm reduction, and with lived experience and clinical experience, thinking of New Brunswick, if we could sort of wrap up and go around it, but what is the biggest barrier? What's the principal obstacle that we're facing when it comes to introducing effective harm reduction in the province? First, that's a simple question. That's a gentle lob. And I don't mean to be bright, but I think, yeah, go ahead, Tim.
Yeah, so once again, the barrier is people. So systems are people. People make policies, people deliver services, people work in the jobs, people make the decisions. So it is simply people, and they can change how they deliver their services or the policies they implement and that type of thing. And the problem right now is that in New Brunswick, we've allowed systems to respond organically to problems. And when you let a system respond organically, it usually does it in the most inefficient, wasteful way possible. So if we make strategic, intentional decisions in New Brunswick, our problems are manageable.
So, Mayors, do you want to leave us with a final thought from your lens, the biggest obstacle?
Sorry, who did you address that to?
Oh, I addressed it to you.
Oh, okay. I heard only part of what you said there.
Yeah.
But I see that in the chat, Deborah Warren said stigma and discrimination as you were asking that question about some of the issues, and I couldn't agree more that that's such an aspect of the issues that that are a challenge. The other aspect is also when you look at this group of people, it's a wonderful, amazing group of people who have their hearts in the right place. And obviously, if you're going to attend this conference, you're going to be the type of person who's going to want to be making changes. And I think one of the biggest issues that we have here in New Brunswick is just the communication amongst everyone. And so this is where panels like this and conferences like this, where we have a chance to discuss, and I hope that it can continue on, because certainly things like the government are very organized at being able to make policies against people who use substances. So I think we need to be able to be just as organized in protecting people who use substances.
Intrinsic bias is another statement there in the chat.
Yeah.
Before we continue, just wondering if somebody wants to tackle what the panelists feel that if there were more money to focus and put towards mental health services and supports, do they feel that people would be less apt to lean towards substance use?
I think that really goes back to Tim Christie's discussion on what are the basic requirements for life, and you can't tackle mental health without tackling basic survival. And you can provide all the mental health care that you can, but if somebody's living in a tent and is looking for a meal every single day, you're not going to be able to manage their mental health issues. And you're not going to be able to manage their substance use issues either. The number of patients that admit to me that they used the night before, not because they wanted to, but because they were terrified of falling asleep in a dangerous situation. So they're going to be using stimulants. I think that needs to be addressed as well, is that if they're living in an unsafe environment and their basic needs are not met, we can't really tackle the substance use or the mental health issues. So right now we're a Band-Aid.
I would also add to that we have well over 100 people sitting on our wait list for concurrent rehab, and the wait times are currently between 8 months to a year. And in my opinion, that is unacceptable. And I don't know what the solution is to this problem, but I do know that a lot of money would help me solve the problem. So I do think money would be useful in that. Like, it would be lovely to have a lot more resources, a lot more beds, so that we can move through this wait list. Because we know when somebody is when somebody wants recovery and they're choosing that as their path, they want it then. They don't want it in a year. They don't want it in 6 months. They don't want it in 4 weeks. They want it in that moment. And unfortunately, that's not something that we can do for them today. And that is the dream. That is the goal. And I'm not sure how we're going to get there, where we can have, access to care, when a person needs it and wants it. But money would be helpful.
It's not the answer to everything, but it sure helps. Go ahead, Dr. Myers, or did you have something to add? No, okay. Em, do you have any final words?
Yeah, so I guess my kind of final thoughts, kind of the last kind of thing I want to say, is that kind and compassionate care, harm reduction, it doesn't enable anything but access to care. And I think it's difficult because there has been a culture that I have experienced, at least, of tough love, and that's what's needed. But I heard a quote the other week, and I thought of harm reduction and the panel right away, and it's something that I really want to make sure I say before I go. And I wish I remembered who the quote is by, but there's nothing that tough love can do that loving firmness can't do better. It is so important to support folks, and make sure that they feel supported in that. and again, changing policies are important, but changing culture is so important too. Because yeah, it just, yeah, thank you.
Truer words never spoken. Give a hand up is so important. Thanks, Em. Holly, did you have some final words?
I would say that misassumptions around what harm reduction is one of the biggest barriers to successfully treating people who use substances in all the variety of settings. And the other barrier, which I had kind of mentioned several times, is the disconnect between the different, like between, government, inpatient, community, non-for-profit. And I know there's great groups, just like the Harm Reduction Symposium Planning Committee, who work together. But there is disconnects, and I don't know what the solution is and how we can break down silos and build bridges and impact the care that folks who use substances receive so that they can flow seamlessly across the continuum of care from community to inpatient to corrections, back to community to inpatient, and they can be followed and not lost to follow-up, because one of the biggest issues I find is people are lost to follow-up, whether it's from internal med or whether it's from rehab or whether it's from being on a wait list and not being able to find them when a bed does become available. And I don't know what the solutions are to these problems, but I think if we can get the senior leaders that, might have some misassumptions around harm reduction to work together up here and we can build bridges, I think it might have a really positive impact on these folks. So that's what I'll leave the panel with.
Well, thank you for that, and thank you all the panelists for your appearance here today. It's been a fast hour. It's gone quickly, and I want to thank those in the audience that submitted a question or made an observation. It certainly made time go quickly, and I think offered us a rich conversation with lots of takeaways. I'm taking away a rural piece that I probably didn't give enough attention to when you think about harm reduction. Certainly Tim's comments about systems, the idea of changing culture, and no doubt about it, the basic needs deficit that continues to hold a lot of New Brunswickers behind. Thank you all very much.
I'd just like to
And-
add, if we didn't get to
Sure.
everybody's question in the chat or in the Q&A, and I think there's some discussion about the chat not potentially being open to everybody. So we'll have a look at that because there are some really good links there. And obviously by all of the excellent questions and very passionate responses, we have many fabulous people around the table who want to tackle this really complex issue. And I agree, Holly, we need to break down the silos and have a really big table and a huge conversation together, not at separate tables. I think that's really important for sure.
Great, thank you again. We're going to move right ahead. Next on our agenda is Kim Wilbur, who's going to be offering a memorial of those lost.
Each year, I have the honor to ensure that we take a moment to remember the individuals who we've lost. And I'm so thankful that the family and friends and care providers have shared this list with me. I believe that in the first year that we were together, there was 40 individuals who had their names submitted for remembrance. And sadly, this year, I have over 300 names. The name of our Harm Reduction Symposium this year is very appropriate. I'd like to review the names with you and take this moment. I may read a little bit more quickly this year, but that's not to take away from the loss or hurt. of no longer having these individuals in our lives. And I'd like to preface that I can appreciate if some people are finding this difficult. Gail, Ron, Austin, Patricia, Sheila, Jared, Derek, Shane, Angela, Brian, Michael, Marilyn, Gavin, Adam, Stacy, Richard, Gary, Alexander, James, Lois, Patricia, Marie, Christina, Naomi, Wayne, Robert, Kevin, Melissa, Robert, Pauline, Noel, Nolan, Brittany, Michael, Cindy, Sharon, Ivy, Paul, Jenna, Tiffany, Karen, Kenneth, Corey, Vicky, April, Bruce, Rusty, David, Charlene, Matthew, Joni, Hayden, Tegan, Lisa, Sean, Sharon, Bambi, Jacob, James, Dustin, Lisa, Sheila, Nicholas, Tanya, Carrie, Robin, Valerie, Shannon, Donna, Kimberly, Stephen, Andrea, Tara, Skylar, Wayne, Patricia, Linda, Christopher, Paul, Shyla, Beamish, Mindia, Courtney, Terry, Vaughn, Gary, Aaron, Kane, Corey, John, Trevor, Jermaine, Stefan, Brittany, Margaret, Rose, Alec, Roger, Kelsey, Brady, Michael, Vicky, Nicole, Kelly Kitty Cat, Brianne, April, Neil, Brent, Daniel, Darla, Ray, Corey, Peter, Amy, Jonathan, Jeffrey, Gary, Brittany, Victor, Ryan, Joseph, Marc-Andre, Mathieu, Jenny, Tabitha, Miguel, Anthony, Aaron, Lucas, Mariah, Jamie, John, Jason, Wayne, Tanya, Brianna, Richard, Anthony, Alex, Brian, Serge, Mike, Jason, Matthew, Kevin, Shannon, Daniel, Tracy, Odessa, Edward, Ashley, Carrie, Rebecca, Mary, Kyla, Tyler, Mark, Baron, Michael, Bonnie, David, Wayne, Mo, Luke, Lucy, Corey, Donald, Jervan, Alexander, Ronald, Kevin, Rebecca, Terrence, William, Jacob, Diane, Karen, Erica, Kim, Danica, Chris, Tony, Kevin, Lucas, Michael, Conrad, Daniel, Shaylin, Mike, Dylan, Samantha, Jason, John, Stephen, Lindsay, David, Jeffrey, Gregory, Sharon, Arthur, Michael, Angela, Jeremy, Ed, Jenna, Luke, Paul, Andrea, Nicholas, Michael, Gary, Karen, Lisa, Nicole, Richard, Tara, Neil, Angie, Corey, Valerie, Ron, Robin, Melissa, Michael, Linda, Wayne, Gary, Kenneth, Patricia, Jordan, Doris, James, Terry, Brian, Carrie, Cindy, Daniel, John, Shane, Christina, Courtney, Shannon, Lois, Jenna, Brent, Marilyn, Stacy, Wendy, Sheila, Austin, Stephen, Skylar, Corey, Tanya, Robert, Gail, Alexander, Mindy, Patricia, Shane, Nolan, Shannon, Gavin, Dustin, Jared, Donna, Christopher, Tiffany, Brittany, Sheila, Aaron, Kimberly, Kane, Ivy, Jacob, James, Sharon, Pauline, Gary, Robert, Adam, Kevin, April, Linda, Joey, Rayanne, Jonathan, Bruce, Elsa, Amy, Odessa, Alex, Wayne, Shane, Darcy, Derek, Jordan, Gail, Jill, Colin, Taylor, Danica, Mark, Jenna, April, Vicky, John, Tabitha, James, Russell, Maud, Dicky, Gordy, Jordan, Amanda, Chantel, Mark, Dean, Ronnie, Brittany, Gary, Jeffrey, Chris, Kim, Erica, William, Terrence, Danica, Farron, Mark, Karen, Trevor, Brenda, Michelle, Danny, Jeffrey, Quentin, Jordan, Andrew, Rebecca, Alexander, Shannon, Wesley, Jason, Jordan, Ray, JD, Robbie, Johnny, JR, Travis, April, Gavin, Adam, Robert, Ryan, Jody, Chris, Winlin, Woody, Tyler, Annette, Parnell, Richard, Jesse, Caitlin, David, Rafi, Alex, Daryl, John, and Adam. Thank you for taking a moment to remember these individuals. And I think based on the conversations this morning, we have more power when we're together so that we can do something. So this list is not long. It's very short in the future. Thank you.
Thank you, Kim. I think we'd all appreciate a break right now. We'll convene at 1:35 and we'll hear from a guest speaker from Alberta and convene another panel to talk about something that's top of mind for everyone, and that's housing. Thank you very much. We'll see you back at 1:35. Good afternoon, everybody, and welcome back. I want to thank Kim again for that memorial. It was a very touching part of our symposium, as it is every year. But we'll kick off the last afternoon session, the last part of our symposium, with a presentation by Dr. Catherine Dawn. She'll be speaking about supervised consumption services for acute care hospital and emergency department patients. Now, the only reason Dr. Dawn didn't start us off this morning was the 3-hour time difference between Alberta and the Maritimes. It's still morning for her, but not early morning. Dr. Dong is the Alberta Health Services Chair in Emergency Medicine Research at the University of Alberta and an addiction medicine physician at the Royal Alexandra Hospital in Edmonton. She also has a Master's in Population Health from U of A. Her clinical and research work focuses on improving healthcare access and outcomes for people who use substances, particularly those accessing services in acute care and emergency department settings. 10 years ago, in partnership with the community, she led the development and implementation of the Addiction Recovery and Community Health Team at the Royal Alexandra Hospital. She is also chair of the Addiction Medicine Area of Focus Competency Committee, the Royal College of Physicians and Surgeons of Canada, and the Social Accountability Lead for the Faculty of Medicine and Dentistry at the University of Alberta. Good morning, Dr. Dawn.
Thank you so much for having me. It's such a pleasure to be here. I'm going to pull up my screen and we'll get started. All right, thanks so much. I'd like to acknowledge I'm joining you from Treaty 6 territory, Métis Region 4 here in Edmonton, Alberta, and just very, very grateful to live and work here alongside Indigenous peoples who have stewarded this land for generations since time immemorial. Here are my disclosures. So I do have some research funding from the College of Physicians and Surgeons of Alberta and the Canadian Research Initiative in Substance Matters, or CRISM, CIHR, and Health Canada. I have accepted honoraria from the Edmonton Zone Medical Staff Association for some committee work. Otherwise, my income comes from an academic salary from the University of Alberta, and I had a previous medical leadership salary of health services. My clinical work is remunerated through an alternative relationship plan with Alberta Health. My hope is that by the end of this session, you'll be able to appreciate the factors that made opening a supervised consumption service in one of our hospitals in Edmonton possible. I'm going to share all the early lessons that we've learned in doing this work with the hopes that you can learn from some of the mistakes that I made along this journey. And I'm hoping you can think about during this presentation just some next steps in your local context for improving hospital-based care for people who use drugs. So first, I'd like to start by talking about how we learned together and some of the conditions that made actually opening a supervised consumption service possible. So I'm going to take you all the way back to the beginning. So I'm an emergency physician by training. And in the emergency department, I really began to see that we were just not providing good care for people who use drugs, and that there was a lot of conflict and a lot of health consequences to people, the people that I was seeing in the emergency department. So one of the first things I did was survey our patients presenting to the emergency department who were presenting related to substance use or related to houselessness, and ask them, you know, what sort of care do you want to receive when you come here? What are you hoping for? What could we do to serve you better? And it really became clear from that early work that many people were very, very interested in receiving additional supports that we were not currently offering at the hospital, and that the vast majority of people were actively working to reduce their substance use. We really were not able to meet any of those unmet needs in a robust way. And our current model of care at that time did not align with their vision of what we should be doing and what should be available when they accessed our hospital. So we really, really needed to do better. And it was that pilot data that allowed us to secure a large grant from our hospital foundation, which really has championed this work since the very beginning. So we were able to secure an initial $3.5 million grant from the Royal Alexandra Hospital Foundation that allowed us to start the Inner City Health and Wellness Program. We then worked very collaboratively with community and hospital partners to entirely rethink model of care that we had at our hospital. So this was a very, very proud day for me, almost exactly 10 years ago. I can't really believe it, but we're coming up to our 10-year anniversary of the launch of the ARCH team. This is our community advisory group opening the program on July 14th. I'll tell you a little bit about some of the things that we do on the ARCH team. So one of the things that we've done is really standardize our intake and assessment procedure. And this has helped, I think, uncover a lot of unconscious biases many of us had in the hospital around social determinants of health and some other things. So that's helped us, I think, take a lot more standardized approach to make sure we're not missing opportunities for intervention that are important to our patients. We've been able to offer comprehensive evidence-informed management for all substances of use. So this includes making recommendations for intoxication or withdrawal, starting all forms of opioid agonist treatment, including there was a period of time where we were able to initiate injectable opioid agonist treatment in hospital. We offer counseling and peer supports, and we also focus a lot on social determinants of health. All these interventions really have been driven by our community advisory group, which is a group of people with lived and living experience of substance use. Many of them have also experienced houselessness, and we've really taken our direction of what we should be offering from that group. So the things we focus on in hospital are housing, making sure people have a legal source of income, and photo identification, and having an Alberta healthcare card. So those are really important things for accessing other services, as you know, in the community. We actually were able to partner with Alberta Health Services and open an ID office in our hospital. And all of our peer support workers are trained in that ID process. So in hospital, we can now actually help people get photo ID and take them out to pass on registries to complete some of that work while they're admitted, if it's medically safe to do so. We've also done a lot around health promotion. So that includes screening for sexually transmitted and bloodborne infections. We have a partnership with our public health department, so we offer vaccinations, and we also offer a variety of different forms of contraception, again, all driven by what our patients are hoping to access when they're here with us in the hospital. And we've really tried to create robust connections to primary and community-based care, recognizing that many of the patients we serve at our hospital will require ongoing care in the community. And we want to make sure that connection is as streamlined and as accessible as possible, because often people were falling through the gaps in care, be discharged with no notification to the care that they were connected to in the community, or they didn't have care already in the community, and we needed to make those connections. We do also have a clinic where we refer patients from the hospital who are going to have challenges or do not have, who are going to face multiple barriers to the services that we have in the community, or where there is no care available that's going to initially meet. And those are patients we bring back to our clinic to really work on a whole variety of different things while we work on transitioning their care to a long-term provider in the community. So some of our guiding principles, which were really important when we were thinking about starting a supervised consumption service, was that we take direction from our community. They really are the vision and brains behind this program. And I really viewed my job at this time when we were setting things up as figuring out how to operationalize that vision in a very complicated and archaic and hierarchical healthcare system. We focus on reducing harm, respect, and empowering people to make healthy choices. We focus a lot on trust and relationship building. We use a broad definition of health as defined by our community advisory group. And we really have tried to make our research and education very action-oriented and as accessible as possible. So this paper, really stood out. I'm going to take you through a few key things that really stood out to me in the literature as I was thinking about how we could improve hospital care. This paper is from 2009, so a long time ago now. And it was really the first time I thought about, should we have harm reduction in the hospitals? I'd spent a long time volunteering in our downtown core, but this just wasn't seen as within the scope of acute care services for some reason. But there's been a long-standing call for a better integration of harm reduction services into hospitals. So yes, the answer is yes, it's time, long overdue. It also took me some time to understand the experience people had in the hospital. And this was another paper that really stood out for me, that people who use drugs did not feel safe inside the hospital. And I think it took me some time to wrap my head around that. And I think other people that I work with in the hospital, I think we feel very safe going to work in the hospital. And we feel like we talk a lot about patient safety, and we have a number of initiatives to make sure people are safe when they're at the hospital. But of course, that is not true for many patients that we serve that come into the hospital. But back at that time, we had to really take some time to understand and reflect on why it might actually be dangerous, more dangerous to be in the hospital than in the community. So there's many reasons or factors that play into this. Certainly, I think a lot of hospitals have abstinence-only policies that are written or unwritten. there is this expectation that you're going to stop drinking, stop smoking sometimes, and stop using drugs while you're admitted to hospital. Often we do a very poor job of managing pain and withdrawal in hospital. We know that's one of the major reasons why people will initiate their own discharge from hospital. There are still a lot of stigma that exists in healthcare settings. And there really was at this time limited access to evidence-based treatment for substance use disorders. So we were not offering, what would be considered the standard of care. We also, people are not able to practice harm reduction in the hospital. Edmonton actually was the first place in Canada to have a take-home naloxone program. So we had spent, a decade already teaching people about naloxone, getting naloxone out into our community, talking about not using alone, and having that support group with you and how to keep each other safe. But then people would come to the hospital and that was really not practically possible. We weren't providing naloxone kits. People were often using by themselves due to stigma. They were disconnected from the usual group that they would stay together with to stay safe. So people were not able to do any of the things that we had talked about in terms of in the community. And people had to make very difficult decisions about what was safest and healthiest for them. And often that would lead to leaving hospital because it was too dangerous to stay in hospital. It took me really some time to understand, how often that was happening and how significant that was. And of course, that leads to increased morbidity and mortality, which is exactly what we were seeing in our hospital setting. There was also literature coming out around this time that really suggested people would be willing to access an in-hospital supervised injection facility or supervised consumption service should it be available to them. So this was really another turning point kind of in my thinking that, we should really be considering something like this, and that, 68%, that's a lot of people who would be willing to access this if we were able to offer it. So I think all those things together really, for me, started to make me think differently. I really want to give a shout out to the Dr. Peter Center. This was a fantastic paper that suggested that being a participant of the Dr. Peter Center, where they've had a long-standing area where people can use substances under medical supervision, that this was independently associated with a lower odds of leaving hospital. So there was quite potentially added benefit in terms of keeping people in care and helping them address their other medical issues. And I had a chance to tour this facility along with Insight. And again, just really foundational, and want to give a shout out to the teams in Vancouver who've really pioneered this work in Canada. We were also seeing around this time, more and more evidence that really showed the benefits of supervised consumption services in the community setting. So really strong signals and good evidence that these types of services led to a reduction in overdose morbidity and mortality, that there were reductions in syringe sharing, that they were really an important conduit to getting people connected to treatment and services. They reduced improperly discarded syringes and public drug use. There was really no evidence or signal of harm, so no increase in crime, and that they were incredibly cost effective. I think if we had other, if we had other medical things like that were, had this strong of an evidence base or showed this much benefit, we would not hesitate to implement them widely. For some reason, supervised consumption services have been seen differently. Really quite a lot of evidence that we should be moving in this direction. This for me, though, was really when I became quite clear to me that we needed to proceed locally. So this was one of the first papers that we published about the ARCH team at the Royal Alex. And, really grateful to our patients who participated in this, because it really shaped our thinking about what was the next step. Getting the service off the ground was great, and that was really, really important, but we really still had so much to learn about what we could do better. So I wanted to share this quote with you. So what happened was the addiction medicine consult team clinician gave me the supplies and stuff, and then I go and use them in the bathroom, and the unit nurse told me I was discharged because I was using drugs. So they kicked me out. Well, tell me, why is it that they got this no drug use policy yet still go around giving out syringes? So, once I got out of the emergency department and upstairs where I hadn't been for a decade, it really became obvious to me immediately that there was a lot of substance use that was going on behind closed doors. And at that time, it was a lot of injection drug use. And we were seeing patients that would get recurrent infections in hospital. So it was one after the other after the other. And then all of a sudden, I was asking one of our patients, several of our patients about why that might be. And it became clear that there was no access to clean syringes in our hospital, which is full of syringes, which I think is the place, quite possibly the situation at other hospitals as well. So one of the first things we did very quickly was start to offer syringe exchange, which I think was great. It's a piece of the puzzle, but clearly, with this quote and talking to other patients that I was seeing on the units, this was not enough. And it actually created a situation where we were still seeing ongoing conflict because, we didn't have the policy and procedure suite to really support that. So the conclusion from this paper and these interviews that we did with our patients, that we need to think about incorporating other things into our model. And that included in-hospital supervised consumption services, managed alcohol programs, injectable opioid agonist treatment. And these were really the next steps for us. And I'm pleased to say we were able to operationalize all of those. And again, very grateful to our patients for participating and helping us see what our next steps should be. So one of the things I learned, from this work is that no matter what I thought, if you had told me I'd be spending a lot of time trying to open a supervised consumption service in hospital 20 years ago, I wouldn't have seen how the path to that was possible. This is not something I ever learned how to do in medical school. But, our community was asking for something. Science was telling us it was a good idea, and, we had to take action. So what did that look like? What did that look like, taking action? So there were a few other things going on around this same time. So one of them was that I was part of a committee that was trying to operationalize supervised consumption services across our city. So there was a lot of work going on with that regard. And it also became clear to me at this point that if we were going to offer these services in the community, that when people came to hospital, we were going to offer quite a substantially lower standard of care than what they could access in the community. And that's not right. Hospitals, especially large academic hospitals, really offer the highest level of care possible. We get patients in transfer from across all of Northern Alberta. Yet in this case, we were not going to be offered, the same standard that they could access several kilometers from our hospital. So I broached this group and we talked about working in partnership. So when we were putting in our applications to Health Canada for community-based service, I was able to leverage that work as part of our hospital-based application. So it really presented to Health Canada as a continuum of supervised consumption services across our city. And that dramatically cut down the work required for me to start a hospital-based service. But I think also we really wanted to offer that full continuum of care and worked in partnership with a number of different organizations to make that a reality. So this is our hospital. This is the Royal Alexandra Hospital. We have 890 acute care beds, and we have about 90,000 emerge visits annually. And what we were hoping was that this would become part of the standard of care. And I think our hospital is very proud to offer a number of specialized services for different patient groups. And what I really wanted was for this to be be the same, for us to be a leader in this field nationally, and to help people think differently about what that might look like. We really approached it from a patient and staff safety lens, which I think aligned with some of our goals at the time. So I think aligning some of these things with the vision that the hospital has and the strategic plan, I think that was one thing that was very, very helpful for us early on when we started having these discussions. So as you might imagine, this took a lot of engagement at the hospital site. So, we needed support from senior leadership, and we needed to really help senior leadership understand what this could look like and why this was important for the communities that we serve. So we, at that time, had exceptional, and we still do have exceptional senior leadership. So the facility medical director, who was my boss, was very, very supportive of this work. And really, I think, went to bat for me many times that I didn't even know about, that I know about in retrospect, when his colleagues were perhaps questioning what we were talking about and what was going to happen at our hospital. So I think having really strong engagement from senior leadership, that was one of the things that set us up for success, both on the medical side, but also from our senior operating officer, were very strongly in support of us moving forward in this direction. We also had to get buy-in from frontline staff. So I think this would have been hard for us to pull out of the gate when we first launched our service in 2014. But we had been operating for about 4 years, and I think we had generated a lot of local champions. People were really happy that we were able to provide better care. It made their work easier when patients were not in withdrawal and they were accessing excellent care and being started on treatment. That really reduced, I think, a lot of the stress that our staff were feeling around not being able to do things and seeing the harms that were ensuing as a result of that. So not that we had 100% buy-in. I think if you wait for that, that's going to be a long time. But I felt like we had enough frontline staff that were willing to at least try this to see if this would make a difference for our patients. In my experience, what I experienced was that the most pushback we got actually was from physician colleagues who really had a hard time understanding this and were concerned about the reputation of our hospital. Was a big concern that was brought forward. And because we had such strong senior leadership, that was really how we pushed past that resistance. So we thought about it, there are other procedures that we do at our hospital that were launching around that time. Medical assistance in dying was one of them. So our facility medical director said, if we can get this off the ground and you are not comfortable as the most responsible physician, my expectation is that you're going to transfer care of that patient, similar to what you would do for some of these other things that we were offering at that time as well. So our senior leadership really took a strong stance in support of this, which was really, really critical. Other key stakeholders and involvement was important. So making sure our foundation was kept in the loop and supportive of this as the primary funder of our addiction medicine service at that time was also really, really important to me. But, grateful that we had that support and we were able to move ahead, obviously. One of the things that when we were preparing our Health Canada application was around community and making sure we had enough community engagement. So I just wanted to mention that for us in the hospital setting, community, we defined that because this service was not open to any public members. It was open only to hospital inpatients when we started, that we defined community as our hospital staff and patients. And so for our community engagement, for our exemption from Health Canada, that really was around talking to our frontline staff. And that includes everybody. So it was literally everybody: facilities and maintenance, protective services, environmental services, physicians, nurses, RTs, OT, PTs, like everybody. We had sessions with everybody to get their feedback and to document that consultation process. Some of the things that were really helpful, I think, in moving this forward were how we framed it. And so we took a stance around safety, like I mentioned earlier. So really focused on patient safety and staff safety. At that time, we were having a number of drug poisoning events in admitted patients on the units and across our hospital campus. And that was extremely dangerous for patients. And we had, I suspect, were some deaths related to drug poisoning admitted hospital patients, which is obviously not acceptable and entirely preventable. So that was of grave concern to me. And it got to the point that I would be on clinical service and I would go home and I would worry all night about, is everybody going to, be okay when I get back in the morning? So this was becoming more and more an issue around patient safety. There were also concerns around staff safety. So when people were intoxicated or if there were sharps that were not disposed of properly, even though we were providing syringe exchange or syringe distribution and personal sharps containers and talking about disposal, we were still having episodes where there were sharps that were not disposed of safely on campus. So that was a concern for staff. We also talked about the standard of care and, really made that point that if this is going to be the standard of care in our community, that we have a responsibility to make sure people receive the same standard of care when they're in hospital, and that we're not putting people at undue risk because they require admission to hospital. So that was another argument that I think really resonated with people. And I think we could generally agree on our site that the status quo was not acceptable and that we needed to do things differently and try different innovative ideas to make things safer for everybody. So that was another way that we approached it. Leaving things the same really became not an option. And there was a lot of moral distress and burnout, I think, related to, particularly when fentanyl made its way to Edmonton around 2015, 2016. This was becoming an increasing issue at our site. And the other thing that we really did was to minimize the burden on frontline staff who were already feeling tired and overworked. And this is all before COVID. So all we said is, we just want you, if you identify somebody who you think may benefit from this type of service or from seeing our consult team, all we want you to do is call us. Just put the consult in and we will happily come and talk to that individual, do a full assessment, and have those conversations. If you're not sure how to start them or initiate them, that's all we want you to do, is help us identify people who might benefit, and then we'll take it from there. And of course, our goal was to role model some of these conversations, but we wanted to make it as easy as possible for people to connect people to our team. So that was another thing that I think was really helpful, that we didn't put additional burden on our frontline staff when we were thinking about opening this type of service. So I think one of the things I've learned here is that just to be ready, that this is a picture of the stars aligning for me to get this service open. So, we did find ourselves at a point that we had a hospital that was ready enough for a supervised consumption service that it was possible to think about it. We had a municipal government that provided a letter of support for our Health Canada application. We had a provincial government that was willing to fund the service and actually fund the renovations that were going to be required to retrofit one of our old hospital wards to accommodate the service. We had a federal government that was willing to provide a Section 56 exemption from the Controlled Drugs and Substances Act. Once this window opens, I felt like it would never close, but these are actually very brief periods of time, now that I have a bit more experience. And I think you can never count how long these windows are going to be open. So, thankfully we were ready and we were able to move very quickly to get services open in our hospital, but also across Edmonton. So just be ready and watching for these opportunities. And then when they present themselves, just run as quickly as you can to get as much done as you can, because you just don't know how long these windows will stay open. So opening the doors, April 2nd, 2018, a really, really special day for our hospital and our site. So that's when we opened, just after Easter weekend on April 2nd, 2018. So here's a picture of our then Alberta Health Minister, Sarah Hoffman, our MLA, David Shepherd, Petra Schultz from Mom Stop the Harm, myself, and Don Iveson, our mayor at the time of Edmonton. And this was the day that we opened. So let me tell you a little bit about what we offer and where we started and where things are now. So this is a picture of one of our rooms. We have two rooms that are essentially identical. There is actually a second booth back to back with the one that you see here. So each room has two consumption spaces. There's a lot of work that happened behind the scenes here that I'm not going to go into today, but happy to talk more about that if that's of interest. We had to develop a whole policy and procedure suite to support this work within Alberta Health Services. So if anybody's interested in that, happy to talk more about how we did that. But that includes things like who is eligible to use the service, what steps do we take if there's an opioid overdose, what about a stimulant overdose, substances left on site. All of those things are covered by a very robust policy and procedure suite. We also had to work a lot with Alberta Health Services Legal around all the legal implications for that. So there was a huge amount of work done on the legal side of things. One of the other things that became apparent after our Health Canada inspection was that there was a requirement by Health Canada on our site that every single patient have access to a locked safe to store any substances that they might have on their person while they're admitted to hospital. So our hospital actually stepped up, and one of our main towers, which is quite old, did not have patient safes at every bedside. So we had to install a safe at every patient care space in that entire tower. Our newer tower, thankfully, already had that in place, but that was one requirement from Health Canada that we had to take care of before we could open. Initially, our eligibility criteria, we started only with inpatients. So you had to be admitted to the hospital before you were able to access the site. It was not open to the general public. It was not open to visitors. It was not open to patients in outpatient appointments, and it was not open to people from the emergency department. So that was how we started the service as we were trying to get things off the ground and understand what was working and what wasn't working. People had to bring their own pre-obtained substances. And I think I needed to make this more clear in our early communications that we were not providing the substances in the service, because I think there was a rumor going around for a bit that we were providing drugs here for people to use, but that was not the case. So people had to bring their own pre-obtained substances, and people have to provide written informed consent. So that was one of the stipulations. Just like if you were going for a colonoscopy or any other procedure in the hospital, we have a conversation around consent and the risk benefits alternatives of using the site. We have a standardized way that we approach that conversation. So individuals that want to access the site provide written informed consent. And there's also a patient agreement that we developed in partnership with our community advisory group around just behavioral expectations in the site. So things, responsibilities that people have using the site and our responsibilities back as the providers of the service. So what happens is that we have another intake area, which is a bit smaller. So the whole site is, you have to buzz to get in. It's very limited access. It's a card swipe, but very limited card swipe access. And there's a video at the door, so people can present to the service. You don't have to have been seen by our consult service. It's open to any patient. You can just walk over. Or come in a wheelchair. You can come with a porter, you can come with your nurse. It doesn't really matter. You're welcome however you get there. And then you push the buzzer, there's a video. Our nurse will confirm that you're eligible to use the service and then let you in. There'll be an initial kind of nursing assessment. And then individuals will come to one of the consumption spaces. Our team there will provide support if needed with vein finding, making sure the area is clean, make sure people have all the supplies that they want. And then we'll have, eyes on just to make sure people are okay and safe while they're consuming their substances. This is our post-consumption area. So we do ask people to stay with us for a little bit just to make sure they're okay. So that's what this space looks like. The artwork I want to point out because I think it's so beautiful. It was painted by some of the first patients to use this service, and our foundation framed it for us, and we have it hanging all throughout the space, which really, brightened it up and made it a lot more, I think, welcoming. It was quite very much a clinical space when we first opened it. We do have a notification back to the unit. So this is a supervised consumption service. It's not an overdose prevention site. It's fully integrated into all of our hospital services. So that includes, people being aware when they sign the consent form that they know there will be a notification and they're in their chart back to the unit that they attended the service. We don't put the substance in there, but there is a note that people attended. And then we do a phone call to make sure people are okay about an hour later and that they've gotten back safely to their unit and that they're doing okay. But there is we're now on an electronic system, which is relatively new for us, but there is a progress note in that system that people have accessed the service. And that really also, I think we felt that was important for the care team looking after them on the unit to be aware, just in case there were any adverse events that occurred after they left. We wanted to make sure that they were aware that access to the service had happened. So wanted to talk about that. And the other thing I really want to stress is that our community members help to maintain safety and security of the site. So because we built this together, there are things that, we need to do on our side, but we also need to make sure that we maintain a hospital environment, a safe hospital environment for everybody accessing the hospital. And that includes things like making sure or minimizing the amount of drug trafficking that happens on site. And we really want, if people are eligible to use the service, we really want them to come and use any substances that they need to while they're in hospital here, as opposed to other places in the hospital. So we envision this as a shared agreement to making sure that we can keep this service open and maintain our Section 56 exemption and meet all the requirements for Health Canada. That's a shared responsibility. So this is our main paper that we've published about this service. So there's certainly a lot more information in here. But people did start coming. It was a bit slow, but then it really took off. We did have to spend a fair bit of time building trust. I'll talk a little bit more about that. I think it was almost some people felt it was a trap out of the gate, that it was maybe a little bit too good to be true. So there was some apprehension there. But in the first 20 months, we had 7,856 visits by 199 unique patients. About 3,100 of these were for injectable opiate agonist treatment. So our vision when we opened this space was to integrate injectable opiate agonist treatment into the same space, which we were able to do in October 2018. So some of those visits are counted in that 7,856 number. And we actually opened the site, expanded our eligibility criteria to emergency department patients in October 2019. And that was after a quality assurance review where we had an individual present to the emergency department with looking for support around their opioid use, and actually used behind a curtain and unfortunately died in our emergency department. So that was tragic, and really was the impetus for us rapidly expanding access to emergency department patients. So that happened in October 2019. So 35 of the visits in that number were from emergency department patients. During that time period, we had 27 emergency situations, but no deaths. And it really served as, similar to what it did in the community literature. It really helped us identify people who might benefit from referral to our addiction medicine consult team and all the services that we could offer. So it identified 70 patients that we were not following in hospital, but who their first presentation or awareness to our team was that they came independently to the supervised consumption service and were then referred to our team. So part of our protocol was that if somebody came to the service and that we weren't already consulted on them, that it would trigger a notification to their unit to recommend consideration of a consult. Opioids were the most commonly used substance in our service. And we had about 96% of the patients that accessed the service consumed substances through intravenous injection, and about 5% used their intravenous catheter. But this really, very quickly, the service was doing what we hoped it would do, and that was provide a safer place for people who were injecting opioids, who were at really high risk of drug poisoning events on our campus. And it also helped us, it served as a case finding mechanism, so helped us find people who we really would like to engage with in hospital if they were willing. So some of the things that we learned, some of the lessons that we learned, and things that help us keep going when it got challenging. So this is the main paper that we've published about the SCS, one of the other ones that we've published from the patient perspective. So things that we learned. So things that made it hard to go to the SCS, there was still a lot of ongoing stigma, and people were very worried that if they went to the SCS and it showed up on their hospital chart, that they weren't going to get their medication that had been ordered for them. So in particular, this was around short-acting opioids that we use in hospital to keep people out of withdrawal. So we had to do a lot of education on the unit around when it was safe to provide those medications, and that coming to the SCS, if someone shouldn't change your medical assessment, your clinical assessment about whether somebody could receive the medication that was prescribed for them in hospital. So that was one concern, and that made it hard for people to go to the SCS, was ongoing stigma. We also did not allow visitors, and we still do not have supervised inhalation. So we found that there were some people who were consuming substances on site with someone else who was visiting them in hospital, who wasn't a patient and therefore not eligible to access our service. And often in those cases, the decision was made not to use the service. Had still some drug poisoning events on site where it was a patient and one of their close family members. So that was still a gap in care. And then supervised inhalation was the other big one. There was also fear of conflict with hospital staff and protective services. So it took some time to build that trust and to understand that there weren't going to be cops waiting, security wasn't there waiting for you, or it wasn't a trick to get you kicked out of hospital. Things that made it easier to go to the service was our shared goal of making sure hospital is safe for everybody, including staff. So patients really liked that it made it easier to keep a safe hospital environment. They really appreciated being able to use safely and reduce the health risks associated with substance use, and not having to sneak around anymore. You don't have to squirrel away in a staircase and risk getting caught and kicked out of hospital. So I think those were some of the benefits or things that made it easier for people to come to the service. So I think this is me with a naloxone kit. I think, change is hard. It's uphill both ways. And I think I thought that, once we got the service open, that was it. The work was done, but that was not the case. And it still requires a tremendous amount of engagement and support and training of new staff to, still relatively unique in the Canadian landscape that our hospital has this type of service. And we're so grateful to have it. But it's requires ongoing engagement, ongoing commitment. There's been additional requirements around provincial licensing that we've had to take care of. So we now have a federal license and a provincial license. So it's a lot of work, but definitely one of the most important things I think that we have done for our patients. So, as we had hoped, us having these conversations, I think really made it easier for others to have these conversations. And we do a lot of, our nurse educators do a lot of amazing teaching with frontline staff. We've had a huge amount of turnover during COVID. So we've had to get back out there and help create more understanding and get information out there about substance use disorders. But leading by example can really inspire others. And I'll never forget the day when I showed up to see a patient and there was one of my physician colleagues in the room explaining all about the SCS and how important it was and how much they wanted them to go there if they needed it. And I just felt, oh my goodness, progress is being made. And it was just so exciting to see these conversations happen more mainly in our hospital. And this has been a marathon, really, I think, for us. This is me falling down and making mistakes and getting back up and keeping going. That really, you have to pace yourself, and it's not over. There's always more work to be done. We have so much more work to do to really improve care, and so much more to learn from our patients in our community about how we can do better. So really important, I think, to pace yourself. So next steps for us, I'll talk about some of the things that are on our radar and other things that we've learned and things I would have done differently if I could go back and do it again. So if I could go back in time, I would make sure we offered supervised inhalation from the start. It was not part of our original budget, and we did have a very long community engagement, community advisory group meeting about this. Because we did not have initial money to do the retrofitting required for supervised inhalation. The only space that we had in the hospital, was going to be a very expensive and a huge amount of work to do the piping up the side of the building. So we made a decision at that time together to proceed without supervised inhalation. And we have not been able to offer supervised inhalation to date, although I think that is, if we could, that would be one of the most critical things that we could do now. A lot of our patients have switched to smoking their substances during COVID. So I don't feel that our service now is meeting the needs as well as it should. but this has not been possible for us to do. So if I could go back again, I wish we had been able to offer this from the start. And while that window was open, that we'd advocated more strongly for that additional budget to offer that from the very beginning. As we talked about, or as I mentioned earlier, I think ongoing education and advocacy is really, really important. And that keeping these services, even if you're able to start one, keeping it open and making sure that it still meets the needs of the patients that you serve in your hospital is really, really important. And a lot of conversations need to occur on an ongoing basis about all the requirements for this type of service. So it has required a lot of ongoing education from staff and advocacy. We have seen things shift at our hospital. You know, I think part of our orientation now really includes a lot of information about our philosophy of care, including why we have a supervised consumption service. So that's part of the orientation for all new staff. Hiring, we also have questions in many departments have added questions around this in hiring. So I think that we've seen definitely culture change at our hospital over time, but that it takes a long time. And I think I'd love to see expanded access to the service in an ideal world as well. I would love to see patients' family members be able to attend if they're on site as a visitor. You know, I think in certain locations, consideration of having a site that's open to the general public as well as hospital patients, that may make sense in certain jurisdictions as well, especially if there's not widespread access to supervised consumption services in the community. So I think those are all things that we could consider. It has worked well from an emergency department perspective, but again, we don't have access for people visiting our site for outpatient appointments. So I think there's still opportunity there if we were able to make some additional changes in the future. Over time, as you know, I'm sure you're well aware, many of you, that we've seen just the evidence base around supervised consumption services grow and grow. So I think this really is an important part of the care continuum for people who use drugs, and we need ongoing advocacy to make sure every single Canadian has access to this type of service should they need it. And I just wanted to highlight this really great site, yscs.ca, which provides a summary of the evidence in a really consumable form. So when you're having these conversations and advocating for this type of service, I often will share this site with people to help break down the evidence and help understand why it's important that we have these services available in all of our communities. And we've also seen a few other publications related to this. I'm just going to highlight a couple of them here. So one of the nurses that worked at our SCS wrote a beautiful paper about a nursing perspective around inpatient supervised consumption services. And they made the point that nurses should be informed about SCSs and their potential for further implementation, and that existing programs like the one we have at the Royal Alex can be used for implementation in other hospitals, and really stress the really important role that nurses have in terms of advocacy around harm reduction strategies in their workplace. And that includes things like supervised consumption services. And this other article by Kathy Long talked about how supervised consumption services can be conceptualized in the hospital setting, and how it's important to think about the framing around it if this is something you're considering. So they found that supervised consumption services in hospital, and this was done in Toronto, were supported by most of their focus group participants, and that SCS was conceptualized in a variety of different lenses. So as a means to reduce drug-related risks, an opportunity to intervene in people's drug use, as a means to centralize drug use, and really as a transformative intervention for the hospital. So I think proactively thinking about what this could mean for your hospital and how you want to frame it in partnership with your hospital community, but also your patient community, is really important when you're doing the planning for this type of service. I want to give a shout out to the BC group at St. Paul's, who have an overdose prevention site at their hospital. And this is a paper they published about that service. It launched just the month after I think we opened ours was when their OPS opened. So at this time, they were having on average 26 visits a day, and about 20% of their visits were by hospital inpatients. In their service, they found that hospital inpatients were more likely to experience an overdose event. So that was interesting. We didn't have that kind of comparison because it was only open to hospital patients. But I think that's really useful to keep in mind when you're planning these type of services. They also found that opioids were the most common substance. And then really excited to see this Globe and Mail article a few weeks ago about BC maybe moving towards a model where these services might become more available in hospital settings. So I hope that's been helpful to share our experience. I'm really excited to take your questions and hear what you're thinking about for next steps where you live and work. Thank you so much for your time and attention.
Thank you, Dr. Don. That was incredibly thorough and thoughtful. And I assume that there are questions. Nancy, you may be in charge of some of them. I know that the chat has lit up with questions wondering why our province seems unable or unwilling to move in that direction. So I'm sure there are some thoughts that that can be shared with you or some questions.
Yeah, certainly many statements along that line. How can we, one question in the Q&A is, how do you suggest, Dr. Dong, that New Brunswick starts a conversation with around a provincial-based system?
Yeah, I don't know if I have the answer for you. Yeah. But I think it starts with 100 conversations, honestly. You know what, something that our facility medical director told me that really stuck with me is that, you know, what was helpful for him is that we came forward with a proposal, like nothing even written down, but just really an idea about how things could be differently and what that might look like, instead of you know, complaining about what was happening currently. We came forward with an idea and a vision of what it could potentially look like, and then we were able to flesh that out. So from his perspective, that made his work easier because he didn't then have to go away and think about, okay, what is the solution? Or how can we make things different, do things differently? So that was one piece of advice that really stuck with me, that, you know, I'm sure you have already brought proposals forward though, so I know it's a challenge, and sometimes it is just being ready for when those stars align, because things may be out of your control in certain timeframes.
Yes, and sometimes it is all of the stars aligning, and we know that that opportunity isn't there, but it's probably about not giving up. That's a really good point.
And being ready.
We do have ready for when they do align. We do have a hand up in the from the attendees. Can we give Amanda the opportunity to unmute? Go ahead, Amanda. Amanda, if you have a question, you can unmute yourself. While she's trying to do that, in the meantime, there's lots of excellent positive comments here to you, Dr. Dong, about all the great work that's happened in Alberta and in the western part of Canada in general. Amazing.
See, Duncan has a question. Or Webster?
Yeah, thank you. Catherine, it's Duncan Webster. Huge thanks for this talk. This is absolutely phenomenal. Also, I noted your shout out to the Dr. Peter Center in Vancouver, and certainly they have been cutting edge in a lot of the work that they were doing and continue to do. And you guys as well have been pioneers. My understanding is that the safe consumption site at the Royal Alexandra Hospital was the first inpatient supervised consumption site in North America. So extremely innovative. So a couple questions. I wondered, so you answered some of my questions as you went through. You mentioned that by and large, the safe consumption site was used for injection. Yes, it is unfortunate that it sounds like inhalation was not an option or is not an option currently. You mentioned 96% used by injection. The other 4%, what sort of use was that? Was that intranasal?
Intranasal or oral. Yeah.
Oral, okay, thank you. And in terms of others who have seen what you have done in Edmonton and been able to move forward, there was reference to Kathy Long's paper from Toronto. So I gather in Toronto, there's a safe consumption site at one of the hospitals, and then the overdose prevention site at St. Paul's. Are there other hospitals with inpatient safe consumption sites or overdose prevention sites, both across Canada or North America? Do you know, is this something that's being taken up by other hospitals?
No, to my knowledge, I don't think there's one in an acute care hospital in Toronto yet, although feel free to correct me if someone else knows more. BC House is another group that we've been partnered with or shared information with. So I know they do have supervised inhalation, but I don't think they're an acute care hospital. Otherwise, there are some services in Europe, but they are based at hospitals, but don't allow inpatients, is my current understanding.
Okay. So although, this is certainly groundbreaking and pioneering and you've demonstrated the benefits, there's been an inability to get other acute care hospitals or tertiary care centers to set up similar sites for inpatients. And why do you think that is? Is it the bureaucracy? Is it political will? What's holding people back?
Yeah, it's a great question. I think, you need to have a certain amount of volume. Also, our site is open 24/7. We have 2 staff there 24/7. So if you don't have anticipated volume, which actually can be quite hard to figure out, I think in advance, how many people might come to the service. So that, I think cost might be a barrier in some situations. I think the other barriers that we don't think about this, as we do other medical services or other health services, it seems to be different or exceptional somehow. So I think that's still stigma. There's, the exemption requirements and are also, I think, a barrier. Different than getting other services started in a hospital where you don't need exemptions from like a Section 56 exemption, for example. So I think there's a number of different barriers. So I think you have to kind of take them one by one. And it does require strong support at all levels. At least it did for us to be able to get this open.
All right. And you had mentioned that if there was ever a need or desire that you'd be willing to share the policies and procedures. And so thank you so much for the presentation. Just tremendous work and for your willingness to collaborate and support others. So thanks so much.
Thank you very much for having me. I really appreciate it.
Thank you. We do have a question from an attendee, Courtney Miller. Can we allow Courtney to unmute, please? Go ahead, Courtney. You can unmute and ask your question.
Apologies. I accidentally hit the button, but I actually do have a question based on that. I was curious, you mentioned that there's the consents that are signed, and I'm curious how that would work if a client were to come in who maybe had already previously been using. I guess in an inpatient setting, that might not be as much of a concern, but how do you usually approach that?
Yeah, thanks for your question, Courtney. So yeah, our nurses do make sure that they feel the individual is able to provide informed consent and understand, similar to how we would for any other patient or any other test or procedure. To my knowledge, that has not been a major barrier, that people are not presenting in a where they can provide informed consent. I think in those type of situations, patients may be directed to come back a little bit later and kind of have a conversation with them about coming back or returning in a little while if the nurses felt that they weren't able to provide informed consent, or they would likely call our physician to come up and just have another chat, have a chat with the patient and make that decision together. But it's not been something that has commonly been experienced, to my knowledge.
Thank you.
We have another question from Chroma. Can we unmute? Thanks. Go ahead with your question.
Hello, thank you so much for your presentation. My name's Ty and I work at Chroma New Brunswick, which is a youth-facing organization that works with queer trans folks. And as the community that we serve are like exponentially more likely to use substances, and I was curious, as you are located in Alberta, how can we navigate the needs for accessing and in many cases introducing these types of services in provinces like New Brunswick and Alberta that do face gender-based barriers to accessing healthcare services, period, let alone for when compounded with the needs for safe consumption sites?
Thanks. That's a great question. Again, I don't know if I have the answer to that. It's something I've been thinking a lot about also. We are in an incredibly challenging time. So I think one of the answers and one of the things I'm exploring here is just how can we work together to create more understanding, and how can we, I don't know the answer to this either, but how can we create more public understanding about why services are important, and how can we just shift public opinion and public thinking? So I'm trying to educate myself a little bit more about how to do that. But I think collaboration is the key, and supporting each other to see change happen, hopefully in the future.
Yeah, thank you.
Yeah, thanks for the question. I wish I had a better answer for you.
I don't think any of us do. That's okay.
Okay.
That's a hard one. Thanks for your question, Ty. Thanks for your answer, Dr. Dong. Another question another biggie in the Q&A. What do you feel is the best use of non-health professionals, such as peers, volunteers, client care workers, etc., in harm reduction and overdose prevention? And what are some of the challenges that we may need to navigate?
Thanks so much for that question. I am so fortunate to work with peer support workers in the hospital who really are just so instrumental in helping us understand what we can do in hospital and what's most important to that individual while they're here with us. So I think the roles of non-health professionals are just so critical throughout this spectrum. I think they're important in changing public perception in terms of advocacy, in terms of providing care, in terms of engaging people into care. I still feel like there's so many people that won't even come to the hospital even though they're really sick, because there's so much stigma and discrimination that occurs in healthcare services. So I think there's roles throughout that are really limitless. I think we need to have so many more example peers, volunteers, client care workers embedded throughout the system to make sure people feel comfortable accessing care, to change the whole culture of care, to streamline access to services, to help with care transitions. I still worry that we lose a lot of, not lose, but the care transition from hospital to community-based care is still very clunky, and we're often not able to get people directly into other services. So I feel like help in doing all of those things is so critical. So really across the whole continuum of care, I think there's roles, and that currently we don't utilize this to the best of our ability.
Agreed. 20 times over. Okay. Do we have any more questions for Dr. Dong? I'm not seeing anything else in the chat, or other than accolades of thanks, and thanks for your presentation and the great work. And there's still obviously so much to do everywhere. And we have so much more to learn, but it is a learning journey every single day, I would say.
Thanks so much for having me. I'm going to take a few minutes to read some of the comments, and I apologize for not bringing one of our community advisory group members with me today. Normally we do try to co-present, but it just wasn't possible today. But thanks for the feedback. I appreciate it.
Thank you, Dr. Dong. I've been told that I can't turn my camera back on. Somebody must know something I don't know, but we're heading into the home stretch right now. Oh, and now I've been asked to start my video, and there it is. We're ready to start our second panel for the afternoon. We have a stand-in for Chelsea, who is going to be joining us this afternoon. In her place will be Joanne, who I'll ask sort of to say a few words of introduction when we get started. There are three other participants, and I'm happy to introduce them to you. Erin Bigney is joining us. She currently serves as a Director of Research for the Canada East Spine Centre, specializing in orthopedic and neurosurgery spine research, and under her leadership, the Canada East Spine Centre has expanded its reach to include 6 sites, 5 different hospitals. She is dedicated to excellence in research. Her contributions to the field were honored by Research NB, where her team was named Research Team of the Year in 2020. Before joining the Canada East Spine Centre, her work focused on investigating and removing barriers to post-secondary education for individuals affected by generational poverty. Erin is a staunch advocate for integrating research practices into medical care. She recently led her expertise to the collaborative project assessing the medical experiences of high acuity patients living in homelessness in St. John. Ensuring health equity for people who are unhoused is of particular interest to Erin due to her previous lived experience of housing insecurity. We're also pleased to welcome Marcel Lebrun. Marcel is a technology executive and social entrepreneur and founder of 12 Neighbors Community Inc., a tiny home community and social enterprise center in Fredericton. This community and social enterprise are focused on providing housing, developmental support, and progressive employment for individuals who've been experiencing homelessness. The final 96 home was installed just over 2 weeks ago on April the 15th. The 12 Neighbors community is a passion project of Marcel's. Throughout his research and finding some of the best examples of people who are creating lasting change in communities, emerged the 12 Neighbors film series, designed to capture and share the lessons learned. This ultimately led to the creation of the tiny home community. Additionally, through the Lebrun Family Foundation, he and his wife work to establish charities and projects that benefit people impacted by poverty and marginalization, as well as initiatives that benefit vulnerable youth. And before I get Joanne to say something about herself, I'm happy to introduce to you Melanie Vautour. Melanie has been working with individuals and families in poverty for more than 20 years and working in the nonprofit sector for a quarter of a century. She is passionate about social justice. She has worked in women's economic development, street outreach, and support services, as well as developing and implementing housing. Melanie has been the executive director of Fresh Start since 2018 and has overseen substantial growth in the number of her staff and in their impact. Melanie is an inaugural graduate of the Women's Leadership Program from the Coady Institute in Nova Scotia and is a powerful voice in our community. And Joanne, thank you for joining us. If you could introduce yourself and offer a few words, I'll then let the panelists take over.
Hi there. Thank you so much for having me. I'm sorry I'm a late addition to this today, but I operate the group called Street Team St. John, and we have teams of volunteers who go out almost every night of the week now to visit the different encampments where people are living, and we bring them meals that are home prepared meals and essential supplies. The way that I position what we do is sort of like first aid. Our goal is to give people what they need in order to get through until the next day.
Thanks, Joanne. You may have answered my first question, was to provide an opportunity to each of the panelists to take up to 5 minutes if they wish to share their experiences on the topic of housing and health and harm promotion. Joanne, feel free to add a few words if you want in terms of your experience. I know you've spearheaded this group in St. John and have been actively involved in the homeless population and working with them for some time. Is there more you want to offer on your experience before we turn to the others?
I think I'm a baby in this world regarding this effort, but my heart is definitely with it. But I kind of bow and give grace to the people who have been doing this for much longer than I have.
Erin, would you like to share with us some of your experiences and your with the housing and homelessness piece?
Certainly. I'll probably talk a bit about the project we did, which addresses a very specific gap in care and health equity for our patients who are living unhoused. And this is surrounding discharge. There's an expectation when we discharge people from hospital that there's going to be continued care and recovery at discharge. We don't discharge patients when they're healthy. We discharge them when they're ready to be discharged and have continued care. This continued care is not feasible for patients who are living unhoused. And so what is the impact of this? This leaves clinicians with the choice to either keep patients who are unhoused in hospital past the standard time when they'd be discharged, or to discharge them back to the streets, knowing that the expectation of recovery won't be met and is not feasible. To address this gap, we have interest in the establishment of convalescent care housing programs. This will allow for direct discharge of patients to temporary housing at the time of discharge to provide the right care at the right time and equitable treatment for recovery. This should decrease hospital utilization and improve patient outcomes. To the end of supporting this initiative, or the launch of this initiative, we conducted some research with a multidisciplinary team to look at what is the medical experience of unhoused patients currently. So there's two phases. In the first phase, we did a retrospective review of patients who identified as living unhoused between 2020 and 2023 of their medical records. And we found for 50 patients in a 3.5-year time frame, there was 205 admissions. 63 of these admissions were readmissions. That means readmission to the hospital within 30 days of initial discharge. And 73% of these admissions were due to severe infections. There was 885 emergency department visits during this time frame for those same 50 patients. And for across their utilization, there was a total length of stay that equaled 6,035 days in hospital. This is an average of 120 per patient. 56% of these patients had a routine discharge, and as they identified as living unhoused, this means discharge back to the community or to the streets. And then the remaining 35% left against medical advice. In phase 2, we conducted semi-structured interviews with key stakeholders. This included patients with lived experience, frontline medical staff, and community organization leaders who deal services to participants who are unhoused. We had 17 participants with lived experience. 58% of them were female. 47% indicated they're currently living outside or in a tent. 20% were utilizing shelter services, and the rest had a temporary solution to their housing issue. For the patients with lived experience, a lot of the themes that we uncovered have been talked about a lot today around safety, and that safety included in hospital space, that they do not feel physically and mentally safe in care situations. They talked about the importance of relationships. Interestingly here, there was some specific medical caregivers and community members named as being supportive and how much that support meant given the rest of their experiences. Challenge of accessing care, transportation, availability of family doctors, of clinic visits, and additionally, communication for follow-up appointments. They don't have cell phones, email's difficult, they don't have home address. So being able to maintain what they were told to do, even if they get care, was very difficult. Experiences of discrimination, distrust of the healthcare system, the need to meet their basic needs, rejection of care because I can't keep my wound cleaned, I'm not gonna be able to not weight bear, I don't have the capacity, if I don't have a washroom, if I don't have the basic means to meet my needs, feelings of hopelessness around their situation, and trauma. When we talk about the frontline medical staff, this included predominantly physicians and nurses and some administrators. There's also a feeling of hopelessness. They reported passion fatigue from the cyclic cycle of care and having to see the patients go through the same system again and again. They also reported burnout, that they have to choose between what the policy says they have to do and doing what is best for the patient. Communication was a challenge that they noted, one with patients around cell phone access, as well as with the community. We know there are some excellent resources available, but we have to have a bridge and make sure there's open communication between these silos of care for healthcare and the community resources. And also around challenges accessing support. Predominantly for them, that was around social workers working 9 to 5 and being that key bridge. But these patients require service 24/7. They're coming in the evenings and on the weekends, and they don't have that. And with our community groups, we found very similar themes across the board. You can tell they're in touch with both of these groups because they discuss the same challenges accessing support and communication, a breakdown of silos, safety for our patients, challenges of accessing, experiencing some discrimination. So basically, what we found is that the current continuum of care involves exorbitant hospital utilization, with patients still being underserved and stigmatized, and clinicians not feeling like they're able to give adequate care. And hopefully we can use this information to help drive forward a convalescent care housing program.
Thanks very much. Marcel, could I ask you to reflect on or share your experiences on the topic of housing and health and harm reduction?
Yeah, so good afternoon, everyone. Happy to be here. Just 60 seconds on what we do. So the whole journey for me started by asking the question, who's doing the best job in the world of sustainably addressing poverty and homelessness in a way that doesn't just meet the flywheel of needs that goes faster and faster and more needs meeting, but also has ability to, when you come back, things are better, things are transformed. And so I did a lot of traveling, a lot of visiting organizations in Canada, the US, Africa as well, and to kind of put together to learn really. And then that all resulted in what we're doing here. So 12 Neighbors is currently a 96 home, tiny home community with permanent detached houses, full kitchens, bathrooms, fully equipped and independent. And with a context that is, it's interesting. I saw a little dialogue going in the chat around unhoused or houselessness versus homelessness. And to me, a big difference between a house and a home is relationships and community. And so we really see ourselves as community builders first and foremost. And I like to say the houses are an excuse for that. And what our focus is very developmental. So the idea would be is not so much relief oriented, I'm hungry, I need a sandwich, or, the handout thing, but how do we invest in a strength-based approach for individuals to build capacity in their lives? And we do that with 4 things. One, helping people achieve and maintain housing stability. And, that has a number of pillars to it. Living peaceably in community and taking care of a place and not wrecking it, and, controlling a home from, others who may want to take advantage of your asset, those kinds of things. Then it's about helping people, basically that home piece, which is developing supportive, one of the social determinants of health are the supportive relationships in our lives. It's what gets us through all of the challenges. And sometimes people run out of relationships well before they run out of money. And so how do you rebuild that? And then we have personal development programs, which are very comprehensive, like whole life looking at it, everything from, relationships, health, physical health, mental health, substance use, education, all that work. And then ultimately our step 4 is for those who can, path to patient and progressive employment. And so we have these little businesses we're launching in food, retail, construction, to give people a chance to, at their own pace, work on employability which can be a very long journey before they're ready to look at a market job. We take individuals, our community has come off the by names list. We have a variety of acuity levels. I think probably about 95% of individuals in our community either have or had substance use as a big part of their experience. So there would be some that are currently ambivalent about their substance use and not interested in doing anything. There would be some that would be in a kind of a harm reduction program. There'd be others that would be in more of a abstinence-based recovery and a little bit of everything in between. So it's a very prominent part of everyone's experience. And of course, as you all know, there's a lot of co-occurring things that go with it, from, you know, trauma, poverty, mental health, and all that. So that's kind of a picture of what our community is. And yeah, I guess I'll maybe Randy, wait for, I know you guys sent us some questions, so I assume they're going to come a little later. Yeah. Oh, I think
to round out some introductions, or perhaps your experiences, Melanie, dealing with health and harm reduction and its correlation with housing.
Thanks, Randy. So Fresh Start has a housing support program as well as homeless prevention and new homeless outreach. And so historically, as an organization, we've been housing individuals with varying degrees of substance use since 2009. And right around 2014, 2013, we started recognizing that we were housing the same people over and over again. Realized it was due to challenges with substance use. And so that's when we really started looking and saying we needed housing support, and all of the things that Marcel has mentioned around working on building tenancy skills, supporting clients, meeting them where they're at. One of the things when we look at housing for individuals with substance use or other challenges, they're often complex needs and rooted in trauma, is also the advocacy piece with landlords and community. So that's become part of the work that we've done, and it's where we see some of the challenges on why we see increased homelessness and recurrent homelessness with individuals with substance use is because of that bias and stigma that's associated with it. And so for us, it's about pushing back and advocacy in all of our program deliveries to make sure that we're educating and really working to reduce that stigma that's directed towards individuals. And then they're able to maintain housing because they're being treated like other tenants with the same expectations rather than increased expectations, because we know they have challenges.
Thank you for that. Well, it's a great team here. And I have 3 scripted questions, but as always, those in the audience know that if you want to raise your hand or if you have a question you want to pose, by all means, fire away. Our reviews of previous symposiums have indicated that participants and viewers really enjoy the opportunity and valued it to jump in and to participate. So the opportunity's there, and you're welcome to do that. I will, however, put one of these questions to folks because I think it's quite relevant to what we're doing today, and I'd like you to discuss, if you can, the biggest barriers for housing security for people who use substances. What are the barriers that folks are going to encounter when they're using substances? We'll go sort of in reverse order. Melody, you want to start this off this time? Gotcha.
Sure, Randy, thanks. So I think I touched on that even in my introduction. I think it's clear to say one of the biggest barriers is lack of affordable housing units, but that's not limited to any demographic or any, we're all at risk of that. But I think, again, the biggest barriers for individuals with substance use that they face in maintaining tenancy is that judgment, and also what we have seen with 1.5 years in delivery of like intensive housing, a housing first program here in St. John, is that policing of individuals that look like they potentially have substance use or are known or have known to have a history of homelessness. And so this is where, there are complaints due to visitors. And so our automatic assumption is there are 3 people going into this apartment, they must be doing drugs. And so this individual shouldn't be allowed to continue to live here. Landlords who monitor their tenants and their activities and actions, to then complain that they feel there's substance use taking place. So again, it really comes back to that stigma that we have as a society. We're 50 plus years into the war on drugs. And what we now know, I think, is that that's actually been a war on people, specifically vulnerable and marginalized populations. And so that's the biggest barrier, is that when someone is identified as potentially having substance use, we have this community policing that takes place that involves creating risk to tenancy, because we don't want to see it, we don't want to have it. And so for Fresh Start, for our staff, what we know is considerable time is spent advocating and supporting residents, especially with substance use, to really push back against that stigma that they are still able to have friends come over. They don't need to be monitored. And the proof of that is we've actually had video here in St. John from landlords sent to us of individuals of concern entering our participants' houses. It was us in the videos. And so that speaks to that level of judgment that's out there. And I think if we really want to combat that, we need to just do more education and really talk about how everyone has a right to housing, and that we need to stop policing people that we think do have some challenges with tenancy. We expect more of them when we know that they struggle to do it, and that's not fair and sets them up for failure.
Marcella, can I ask you to opine on that? Any thoughts on the barriers for people who use substances in obtaining housing security?
Yeah, a couple thoughts. The first thought is I struggle a little bit with the implication behind the question, and the reason is it implies that people who use substances maybe all have a kind of a similar profile of struggles. And for me, it's really more about how the various co-occurring challenges that individuals have, including substance use or mental health, manifest themselves in behavior. So for example, if I have someone who's ambivalent about their substance use, but their substance use results in them, being in their house for 3 days, and they're non-violent and they're not, threatening their neighbors, that's a very different situation than someone who's, a danger and a threat. And it's not the substance use that's necessarily different between them, it's the way it translates into their behavior. Now, it so happens that, individuals that have behavioral challenges, which make it difficult for them to maintain housing, often substance use is part of that equation. And, if individuals destroy their home, obviously that makes it very difficult to maintain housing, or if they threaten their neighbors. Now, I have a little bit of a different spin or experience, I guess, in terms of what Melanie's sharing, in that one of the things I've learned is that often what we've seen is an individual who, let's say, comes from living rough into a house, and all of a sudden you see there's 8 people coming to that house. And it may appear on the surface that, okay, that person's bringing all these people into their house. A concept called a housing unit takeover, which is where, that person may actually not actually be inviting them in, but others who they're somewhat beholden to want to take advantage of this asset that they now have. And so they can get run over by outsiders who all of a sudden take over their home. Like I've literally had people calling police to ask them to remove the person who actually lives there, you know, because the person who doesn't live there wants them kicked out, you know, and they go to take over. So what you have to do is support the individual to learn what does it mean to be housed and to control your home, so that you choose, you know, who comes and goes in your house. So I have a privilege, generally speaking, people don't knock on my door at 3 o'clock in the morning and I have to like figure out how to, you know, not have them bother me at 3 in the morning, but that's not always the case for everyone. So I think it's supporting people and helping them to develop these skills so that they can maintain their house, maintain control of their house, and you know, take care of it and learn to live peaceably in community.
Thank you for that. Aaron, do you have any thoughts on housing security and people who use substances and barriers?
Sure. Obviously, they're multifactorial, and the first two speakers obviously spoke to that. I'm going to give a very practical barrier that came up a lot in my interviews and discussions with people with living experience is the need for digital tools for cell phones. That's kind of equal to literacy in this day and age for accessing supports that could help them maintain their housing if they already have it, or access housing that may be available to help them connect with supports, to maintain connections, and to help decrease housing security barriers for people using substance. Obviously, that's not going to address the major barriers, but it's a simple step we could take that might help some of this access the resources that are here, or supports that could help them improve their housing security.
Joanne, any thoughts on barriers? Do you want to contribute to this part of the conversation?
I mean, I think a lot of the same points that I was thinking of have been mentioned, definitely cost. And I always kind of see somebody who has had a long period of being unhoused, it's probably a lot like being a fish out of water, to be plunked from one environment completely into another without, you know, if they don't have the support around them to help them kind of reintegrate in that kind of way of living, right? If you've been surviving and you're going here and there to obtain your food and your clothing, well, that might change a little bit for you once you do have housing, right? Because now you have a kitchen that you can cook in, right? You've got, you know, the refrigerator and stove, and well, how do I keep that filled? How do I cook a meal that's not just opening a can of something, right? So I think that there's a lot of skills training that I think people need in order to help them kind of make that transition.
Well, it's about positive change, because I'd like to think that as time has moved on, we have made some progress. This is our 6th symposium. It's been some good learning that's taken place. Melanie, could you tee this one up? What positive change have you seen related to housing for people who use substances?
So I think there's been a lot of work towards better understanding the need for housing support, whether that's teams, you know, different models of housing for individuals, and especially talking about that continuum of housing that individuals need with various levels of support along the way. And we're having those discussions now at even government levels, and kind of this excitement, I guess not for us who have been doing the work for a long time, but to see the excitement in others to be part of this and have those really in-depth conversations around housing support and the need for that and this continuum of housing. So that, I think, is a really really good direction. It's leading to some positive change, and you know, change is hard, but it's happening. And I think too, showing like Marcel with his project in Fredericton, showing that these different ideas and taking a bit of risk can have huge reward, and specifically around, I guess, harm reduction is, you know, there was a time when abstinence and sobriety was what was expected and required for housing programs, and we're starting to see that shift away where it is harm reduction based. And that's just growing and growing and growing as we have more evidence that this is what works and is the way to go. So I think those are really good things that are happening.
Thank you. Marcel, I'm sure you've investigated best and promising practices for your target 12 neighbors. Is there anything since you started your project that has challenged or changed any of those findings?
I mean, I think that, you know, housing people and supporting them on a path to independence gives us as taxpayers an incredible return. It's the business case is so strong in terms of what it costs us to support someone relative to the justice involvement and the ambulance and the healthcare demand and, you know, all of the things that end up happening when someone who's unhoused. If you know, 1 day of regular hospital admission is what, $4,500, I think, in New Brunswick. 1 year of rent subsidies, $4,500. If I just save a day in the hospital with a 1 year of housing, there's a return right there. And so I think that there's a growing, you know, recognition that the business case is good to invest in permanent housing. And one of the biggest things I've learned from my community members is how a lot of our emergency measures and efforts, I mean, I've had individuals who are like, they'd rather be, you know, we have these perceptions like, oh, it's really bad for people to be cold. But there are people who say, well, I'd actually rather be cold than traumatized, or I'd rather be cold than beaten up, and I'd rather be cold than stolen from. And so I'm not choosing to be cold. I'm just trying to make the best choices with what I have. And really, I'm so convinced that permanent housing is the most economical approach and the most effective foundation. You know, it's not the be all end all, it's the start, but then that you can support individuals. And, you know, I think a lot of the thinking's emerged. Everyone seems to understand things need to be person-centric and we need to be strength-based. And, you know, I think a lot of good things are happening.
Great, thank you. Aaron, do you want to jump in here? Any positive change you've encountered?
Yes, I would say definitely within the hospital, there's a shift from previous idea of blaming the person for their circumstances or use history or current use. And that has really shifted to understanding the social determinants of health and the impact of policy on these people and their inability to move forward in certain circumstances. So there's a shift in where they think the issues are lying, and that it is with policy and it is with appropriate supports. And also I would say that we did support for change in how these patients are treated and improving health equity and transitional programming through key stakeholders, and it was overwhelmingly supported. The only concern around change in providing these supports for this population was around the fact they didn't think policy and high-end administration would go for it, but that on the ground, everyone was overwhelmingly supportive that this should be in place, that these patients need our support and help, and that this population needs to be assisted to move forward.
Thank you. Joanne, any thoughts on that? Anything that you've encountered or experienced that would give you some hope, some positive changes you've seen?
Yeah, I think when I first got started in this, and that was in 2022, I was kind of new to this environment. And so I was really surprised to learn of groups like Fresh Start that will help kind of be your advocate once you get into housing to support you and work with the landlord. And to me, I think that's probably a huge change, you know, for the people who work through Fresh Start to get into housing.
Good, thank you. Nancy, did you indicate there was a question?
Yeah, there is a question. I think Marcel did touch on this from the Q&As. Drew was asking, I understand that there are pros and cons to centralized versus decentralized housing options. Ideally, we would have a number of options for housing people depending on what works for them. But when resources are limited, what do you see as the best return on investment when trying to convince government and other organizations and donors to fund and support low barrier housing programs? Great question.
Great question. One thought I have is, I actually think we need to get smarter and more granular on various types of supportive housing. We kind of bucket it all together sometimes, supportive housing, wraparound services, but I think there are contexts that are very healthy for certain type of individuals that are difficult for others. And it's good, I think we'd have much more success, much less eviction or failed attempts if we spent more time digging into exactly what type of support an individual needs and trying to match that. I think like, for example, there could be, let's say there's individuals who just don't have any much for executive function, and their ability to, understand certain things or maintain a home requires a very high level of support. Doesn't mean they can't be housed, but it may mean that they can't be housed in a particular context. And you try to house them in that context and it fails and it affects everybody else. And then now they're back. So I feel like we need more different types. And in that case, it may be that you look at a certain type and say, well, we only need 20 units of this type. And this type, you wouldn't want to put more than 20 together. But depending on what you're doing, you could go with a bigger size. A lot of people, that was one of the biggest things I heard. People were concerned that I was putting, 96 houses together. And it is a lot. Part of it was it's just as hard to build 4 as it is to build 8, in terms of all the process you have to go through. And I wanted to make a significant difference in the housing that's available in the city, but also with community, there's kind of these stats around what's the ideal size community, and 150 people, you end up finding really good friends. You end up finding maybe somebody you don't like, but you don't have to interact with them because it's kind of like in a school that's big enough, you just stay away from that friend and those kinds of things. So there's just lots of factors. My view is we just need more of all of it. Like, we just need more of every different kind. I think we need to get a little more granular and better fit for different folks. And I think ultra low barrier housing is something that we don't really have anywhere here. And I think we could benefit from that too. Yeah. Excellent
points, and definitely not a one size fits all approach. The needs are different. Do any of the other panelists have anything to add to that?
I'll just add to Marcel in St. John. I'm here. One of the conditions for, I think I agree, various types of housing support, which collectively I think we're working towards here in St. John, as identifying that, and we've identified it as the right support for the right person when they need it. But we actually, Hope Team, Housing Opportunities for People to Excel, is extremely low barrier housing. It is the lowest, and it's through a scattered housing model. And there are some instances where we have clustered individuals in buildings for that very reason, that kind of people who need community or feel that connection with individuals on the street. And again, it's that client direction. So just to say that here, we are having opportunities to have ultra low barrier housing and seeing that success in 16 months, well, 18 months now, with 39 housed, we've only had 1 eviction. So in ultra low barrier housing with very, very complex need cases for housing. So Marcel is correct. It works. We get a lot of everything and give people what they need to maintain tenancy.
Great. Now I'll remind people they can put up their hand and ask a question if you want. It's quite a panel we have here with excuse me, experience and reach. But maybe I would move to a question then I don't think it's an unfair one, but we're asking people to think of one change that would have the greatest impact when it comes to housing those where harm reduction is required and substance use takes place. If there was one matter that you would recommend or one suggestion, we're all ears. Joanne, could I start with you? Can you offer one thought?
Well, we've touched on it before, and it's definitely to have the supports in place for the people that need it, and to have it so that it's tailored to what their needs are.
Erin, I'm looking at you now. Do you want to take a stab at that?
Mine's going to be pretty biased based on the research project we did. These are very complex problems. They're going to take a long time to move the needle on. But when there's easy wins, we should do them, such as transitional housing, convalescent care housing, picking vulnerable time points that we can provide supports during. I think that's how one of the steps forward, because they're measurable and easy to implement. And that can move us forward, move the needle at least a little bit.
Thank you. Melanie?
So I agree with Erin, things that are doable. I think to probably mine and Marcel's point is that funding different support models for individuals on a greater scale. I think we need to really start pushing back and collectively saying that, you know, an end to the war on drugs, because it is affecting people in such a harmful way. Everything that comes from the war on drugs is what's leading to some of the challenges that individuals are facing. So I think long term, that can be our collective action. Short term, let's support our individuals that need it right now through housing and housing support models.
Marcel?
I think there's a lot of harm caused because supportive housing or affordable housing is such a lottery. And a lot of our systems, you know, our by names lists and our ranking and all that stuff, it's all needs to be what it is because we have so few, you know, to give out. And I've seen people experience trauma in their interaction with the system because they're just trying to get a little direction on their life. If I do this, do I get a house? If I do that, is it going to be a year, 6 years? What do I do? And who of us would expect someone to figure out how to live on $600 a month, right? And even as a starting point, you just get so behind that without a rent subsidy or some kind of on-ramp, so then you have individuals out there waiting and they just don't know. So I just think that more, you know, less lottery, more, you know, someone got lucky. You know, I look at some of our community members here that I knew them before, and I'm like, if they were still in the wait list 2 years later, I don't know what would have come, you know, but then I know there's someone else who's still on the wait list. So we cause a lot of harm, I think, by making it winners and losers. Lucky you got an offer, you didn't. People perceive it as a lottery, and it should be a little more of a consistent approach, I think, to how we do it.
Excellent insight by everybody. That's excellent. There is a question in the Q&A from Chroma. When working with our youth, there have been a number of individuals in need of housing assistance, but they fall in between the age brackets for service. In St. John in particular, there are places that offer housing assistance for 18 to 24-year-olds when that few places that offer for that age group when compared to the under 18 and the over 25. How would you approach filling this particular gap? Anybody want to tackle that one?
I know the province is working on some redefinition of youth to change the age from aging out at 19 to be able to extend care to, I don't know if it's 24 or something like that. Someone else probably knows. And in our community, we're 19 plus, so I do have 19-year-olds, 20-year-olds, and to the extent that they're able to be nominated off the by names list, they're equally, and I personally feel like, with a young person, our system, our system costs and the need to move them further along to independence is greater. I have from 19 to 72. If somebody's 71 and they're like, I don't think employment goals are in my future, that's okay. But if you're 19, boy, oh boy, that's going to be a long life if you can't figure out, how to get there. So the range of things we need to do to help people get to independence, and in my view, the younger they are, the more, the more important it is and the better return we have if we invest in folks early.
Melanie, you're seldom at a loss for words. What about the youth cohort?
I'm just gonna say, I know I echo Marcel that it is being talked about at the province, and we here in St. John, like we do have youth serving agencies that are looking at that. I think one of the challenges for youth in housing is again that stigma around youth, living independent, all those, stereotypes that apply. They'll have parties, they, will do this or that. And so again, it's that judgment, that bias, that leads to challenges to house and maintain housing for individuals. So we house 19 and up as well, through Hope Team, and our prevention services are available to as young as 18, or younger, depending on the situation. And so, there are things out there. I think collectively, it's to keep moving forward. I know, like New Brunswick indicates, 34% of youth age into homelessness out of care. So that's driving this look at how do we create something that holds on and provides kind of those opportunities longer. And that is being talked about and worked on. And that's a good thing. It's another thing that we need. It will not be enough, right? There's never enough because we're behind, and we're trying to catch up. So it takes a long time to do that.
Well, we have some time left, and you're also capable and have such a wonderful sort of vantage point of the issue of housing and harm reduction. Housing relates to not only availability but affordability, and I'm wondering if we can talk a bit about affordability and the issue and the challenge that creates for so many people. Marcella talked about rent protections or rent controls or rent with subsidies, I suppose, rather than controls. And I know you're not sort of housing affordability experts, but the folks that you work with, the experiences you've had, the research you've undertaken, what's the silver buckshot when it comes to working on the affordability piece to get people into housing? Joanne, do you have a thought on that? Just I know you with street outreach and street SJ. Clearly, that's got to be an issue, and I don't know how, in the absence of a livable guaranteed livable income or lower income supports,
Right.
that we can wrestle this down.
Yeah, I think back to a gentleman that we had assisted with finding housing. He had been living in his car all winter, and the place that we found for him was a renovated hotel room or motel room, without a kitchen. It had a bathroom and a room, to have a bed. But even that was more than the basic income assistance check And I mean, it's difficult, right? It's difficult for all of us to even think people with what we would consider a decent job these days would find it very challenging to pay some of the rents that are out there today. So I don't know, that it's definitely a big challenge for anybody who's in that situation where they have such a minimal amount of income that they get from the province.
Karen, your hand is up. Do you want to go next?
Sure. I just wanted to note too that sometimes the intersection between this population and high acuity needs, medical needs, so having, in addition to living unhoused and having substance use disorder, they also have on average 6 other comorbidities of chronic health conditions they're trying to deal with. And when you talk about affordability or obviously there's the government access, but for capacity to create funding for themselves, to try to do that while dealing with the medical load that they're trying to deal with, it's this intersection that I think gets ignored. That is just not the substance use and the unhousing. It's complex, high acuity patients that are already fighting battles on top of this need for housing and how affordability of the housing and how am I going to be able to do this. So I just wanted to make a note of that.
Thank you. Marcel, any thoughts on affordability?
You know, Aaron brings up a really interesting point. There's a disproportionate degree of medical health challenges that individuals who've experienced homelessness have, and therefore costs of treatment, medication, all these things. And, you know, one of the issues with our quote unquote, you know, social safety net is, you know, like I'm a business person. In business, when you move towards success, you attract more investment. When you move toward failure, you know, people pull back. But in the social context, it's the opposite. When you showcase your deficits, you get help. And when you start to experience strength, the help pulls away. And what I see often is someone who starts to move ahead, these gravitational forces come. Like, for example, I have a community member who, you know, turned 60 and got some employment, and then they lost their white card, and now the medical bills are high, and they're trying to look at this insurance, and it's just like bam, you know. And so there's a very high healthcare load, which is time consuming, limits employment. You know, I've learned stories of people that you know, why do I have this injury? Well, because I made this choice. And you're like, okay, I made this choice, and therefore I deprioritize my own health treatment because this was important. And they are dealing with those consequences. So that's expensive for sure. Housing's expensive. I do like the rent subsidy model that's geared to income. It does kind of seem pretty good. You know, we have people paying, you know, $200 with everything, you know, heat, lights, internet, water, all that. And then some that are now fully employed, no longer getting anything from the province, no social assistance, no more rent subsidy, but they were able to kind of move through that over time. That's really helpful. I'd love to see rent subsidies be much more standards based. So like you qualify if, not you qualify if the lottery calls your name.
Melanie, you're shaking your head.
Well, I agree. I think it's guaranteed living wage. You know, we know this. We saw the impact with CERB money during COVID, you know, and so we know that's needed. And I think, you know, to Marcel's point about rental subsidies, definitely. You know, one of the other challenges is housing is scarce. So we're all competing with each other to find units for people we serve. And so again, it's just like back in the day when we were competing for funding. Now we're competing for housing to do our work and support our clients. So it's always this, you know, forcing us against each other. But I think that the biggest thing, and you know, for us at Fresh Start, is that housing is a human right. It should not be business model that looks to earn profit, it should be, rather than rent subs, rent should be just automatically geared to individuals' ability to pay based on their income, so that standards, and those who can pay more can, but there needs to be something to rein in rent so that it's affordable for everyone regardless. And so the underlying challenge is that housing is really profit based. It's about making money off housing for the vast majority of landlords. And so in that case, our people are always meant to fail. So
Thanks for that. Nancy, do we have any questions?
No, but I would like to remind people that you can be unmuted if you use the raise your hand option. If you have a question for this great panel, now's your chance. Going once. There's some themes in the chat. I think most people can see the information there. Oh, we do have a couple of hands up. One thing that it does seem to be a theme is that in the St. John area, as of last night, St. John and St. Stephen shelters, main out of the cold shelters, have closed. And that's a huge concern for community. Any comments from the panelists about that? Again, another tough one.
That's definitely been weighing heavily on me as well. I worry definitely about the people who no longer have that option,
right,
as a overnight in both places, here and in St. Stephen.
I think, it's concerning, as Joanne said, like we've been working for the last month with individuals that access the Out of the Cold in St. John, around what are some options for them, what can we do, trying to look at, safe couch surfing, rapid rehousing. So, who can we get off the street, which is ongoing for us. But I think overall it's about a question, do we want to continue to invest money in shelter, or do we want to invest money in housing? And so again, every winter comes every year, and we prop up shelters. When maybe if we flipped that and invested the money now into housing, we wouldn't have people needing the shelter come next November, December. So, and until we get to that place, we're going to have this cyclical: open a winter shelter, close a winter shelter, open a winter shelter, close a winter shelter. And the concern is, we forget about heat in summer. Several of us as organizations on Waterloo Street in St. John, have had to call emergency services for individuals suffering from heat stroke. We're running water out the door nonstop. We're trying to find places with shade for individuals. Summer is just as deadly as winter. It's just a different temperature, and we keep forgetting that. So there's so many. I could go on all day, so I'm just going to stop there.
In St. John, though, Melanie, I'm just kidding.
Even in St. John, someday.
I lived in St. John for 7 years, and I enjoyed the foggy air conditioning.
St. Stephen definitely would have that issue. Yeah. I'm wondering, Andrea Ann has a hand up. Can we allow her to unmute? Go ahead, Andrea Ann.
Thank you, Nancy. The housing topic is something, especially around youth, that I feel very passionate about. And I guess my question to the panelists or anyone who else is listening, I agree wholeheartedly with what Melanie was saying, in that we need to look at investing into housing. The unfortunate part right now for youth who fall below the age of 19 is, even if there is housing there, legally at 18 they're stuck. Like 16, between 16 and 18 you're stuck in our province, but 18 you can vote in our province, but you can't legally sign a lease in our province. So can anyone provide insight that helps make that make sense, or feeling along the same lines as myself? Because I feel if we don't start looking at houselessness from a preventative lens, which really is from a youth lens, because I would dare say the majority of the demographic that are in that type of situation right now most likely have some, in some way, shape, or form, touched the foster care system. I feel like we've been working backwards, and just curious how everyone feels. Thank you.
Anyone want to approach that?
I'll just say I absolutely agree with what she's saying, and not because of the project I was involved in, but I happen to have adopted my daughter. I'm very integrated into the foster care system and supportive, and that is a miss, is that graduating out of the foster care system and not having housing plans in place, even when they know of certain issues that may limit housing availability or aging out, and that impact, and that we are just trying to be reactive and not planning ahead for those people. And no, I can't say anything that explains that gap and that 18-year-olds can't sign, but I agree that that is an absolute gap that makes no sense.
Another area for advocacy, perhaps? Okay, there were a couple of others hands up, but they are now down. So there was just one more issue that I see as a theme, and it was really around the community and housing supports. And, you know, what do we do? Any suggestions around what do we do around those communities that don't want this in my backyard? What do we, how do we handle that? That's another really hard one, but it's certainly a huge issue.
I can speak to that, Nancy. So
go for it, Melanie.
So we have the Amazing Hope team, but we also have a CCAN site here in St. John, converted CCANs, which was just this, you know, harder tent was kind of the theory. People here may be familiar that our one of our site was purposely attempted to be lit on fire to try in an attempt to maybe force homeless individuals out. So we have these hard tents that are CCANs. So what started happening in January was Fresh Start actually was maliciously attacked on social media and in community. Staff were being harassed. You know, it was 2 months of a very difficult time. And so we actually started engaging with the neighbors, the people who professed hatred towards us for wanting to support homeless individuals. It was not easy. It was very challenging. We're a feisty group here at Fresh Start, and we had to kind of rein that in a little bit. But one of the really interesting things is we just kept talking about what we were trying to do, and kept offering opportunities for them to be part of it with us. And then they started seeing that we were doing what we were saying. They started reaching out. And, you know, so when you think of it, it's been 4 months. What started as harassment and in some cases like direct threats towards our organization has now turned to being invited for lunch at neighbors' houses. So I think that not in my backyard again comes down to education. I think for us as excuse me, nonprofits, as organizations doing the work, to be really open and honest about the challenges and understanding the challenges for community, but then also finding ways to work together to bridge that. So that's what I'm going to say is it's easy. Sometimes it's easy to just take that hate and kind of hide away. But I think when we face it head on and we did ignore it for a period of time and it kept escalating. And then we just said, yeah, that's enough of that. We're done. And so, you know, the neighborhood of Waterloo Village, I think now is one of our biggest defenders for this wild supported site, we did. So that's what I can say to that: education and listening.
Yeah,
Excellent.
I think I want to echo that. I think that's really powerful what Melanie said, and it's about relationships too, you know, not just education. And I don't like the term NIMBY at all. I don't use it because it sounds like an accusation, you know, like others are refusing to care. But really, I feel like I always advise, you know, when people say, oh, how do we, you know, do something like you're doing in Fredericton in our community? I say, do the work to reach out to everyone around where you're planning to go. And so we do that here, not just the residential, but the businesses. You know, I'm next door to Walmart, Canadian Tire, and all that. I know all the managers there, and we talked before and we talk ongoing. And it's like, you know, everyone does care about their community, and then folks have legitimate concerns as well. And it's okay to admit that, you know, yeah, that's a concern, but let's figure out what we can do. So I always say, take the onus on you as the service provider to try and invest in those relationships and listen to what others have, and it'll go well. Yeah.
I love that positive spin by both of you. That's awesome. That's just amazing and so important from every aspect of what we do. Anybody else? I'm seeing lots of congratulations and thanks for what you're doing, and it's so appreciated, and over and over and over again. And I just want to echo much of the same. This has been fabulous, and it's obvious that we have so many caring people around this symposium today and in our communities, and we've come a long way. We still have a long way to go, but let's just hope that we're getting there. It's fabulous. Thank you so much to each and every one of you.
You're here. Joanne, Marcel, Melody, Aaron, thanks very much.
Thank you.
And we're right on top. Well, we're actually a little ahead of ourselves. So I'm next going to call on Julie Dingwell to bring this to a close. Before I do that and say a few words about her, I'd like to remind people that there is in the chat a feedback survey that we'd love to have. We learn more and more every year from listening to you folks who've been sitting so patiently and observing and contributing to what we're doing. So we value your opinion. We hope that you'll take a few moments to complete that and send it to us. Now it's time for Julie Dingwell, who is the Executive Director of Avenue B Harm Reduction and has been with the organization since 1999. That's a quarter of a century. Avenue B was formed as Aid St. John in 1988, and the organization has been working in harm reduction and HIV, STBBI prevention ever since, opening their needle exchange and distribution program in 1992. Avenue B maintains many key partnerships, including the Sex Trade Action Committee formed in partnership with the St. John Police Force in 2003, aimed at reducing harms to street-based sex workers in the community they live in. Avenue B's work with the Canadian Drug Policy Coalition seeks to reduce the stigma carried by many people who use substances and to work towards a safe drug supply in the country. Julie claims that retirement is imminent, but I wouldn't be surprised if she was involved with the next symposium. And finally, I'd like to share with you that Julie will be recognized later this month as a recipient of the YMCA's Red Triangle Award. In their words, quote, Julie epitomizes resilience, compassion, and unwavering commitment to equity and her community and beyond. I can't think of a better person to close this symposium than you, Julie. It's over to you.
Well, thank you, Randy, for those kind words. And I won't keep people long. I really want to send a special thank you really to the panelists who have given so much time. And we know that you put a lot of work into these presentations and a lot of thinking. So thank you so much for that time and caring enough to do that. I also want to again thank our funders, AbbVie and Gilead, because we wouldn't have been able to do this without them. And like Randy said, please complete that evaluation. We need it. And I always end, I'm always the last person, and I always ask people to go away and do something nice for somebody in your capacity. I mean, one year somebody bought somebody a car. So, you know, we all can't buy people's cars, but maybe you can buy somebody a coffee. If you have a little more money, maybe you can buy somebody groceries. But just do something kind. It's free to be kind. And yeah, our people, especially in St. John, our people are kind people. And so let's just bring that forward and keep on going. And thank you again, everybody, for coming. It really means the world to us. Bye-bye.